Chair Wells, we are now live on Zoom. Great. Thank you.
I'm sorry, I can't hear anything.
Sorry, redo that accident mute itself. That's it. Go ahead, restart. I'm sorry. Good morning. We'll call to order the meeting of the Public Employees Benefits Program Board for today, August 20th, 2026 at 9 a.m. Can I get a roll call, please?
Yes, good morning, everyone. Starting roll. Chair Jim Wells.
Here.
Dr. Keiko Duncan.
Here.
Laura Rich.
Here.
Jim Barnes.
Here.
Chris Baton.
Here.
Tom Zumtobel.
Here.
And Dr. Paul Davis.
Here.
Thank you. Dr. Jennifer McClendon, Dr. Blaine Harper, and Joy Grimmer are absent. We do have a quorum. Please remember to state and spell your name for the record. Thank you.
Thank you. We'll move on to agenda item number 2, public comment. Public comment will be taken under this agenda item. No action may be taken on any matter raised under this item, unless the matter is included on the future agenda as an item on which action may be taken. Public comments to the board will be taken on advisement, but will not be answered during the meeting. At the discretion of the chair, the time for each individual to make public comment, as well as the aggregate time for public comment, may be limited. I don't believe that we need to do any limitations this morning. Additional comment periods subject to similar limitations may be announced for individual items. We will not have any additional public comment periods this morning. Members of the public may make public comments using the call-in number 669-900-6833. The meeting ID is 891-4115-0499#. Persons making public comment, please state and spell your name for the record. We'll start here in Carson City. Dr.
Good morning, Kent Irvin, Kentervin. I submitted written comment on behalf of the Retired Public Employees of Nevada, RPEN, regarding Senior Care Plus and the cancellation of its contracts with primary care providers in Northern Nevada since it was taken over by Kaiser. While PEB and VIA benefits do not have control over network contracts for the Medicare Advantage plans offered on the PEB Medicare exchange, it is disappointing that PEB and VIA benefits have not taken a proactive role in assisting our over 400 Medicare retirees in Senior Care Plus who may have lost their longtime primary care physicians, many of them elderly. They need help navigating how to either get a new provider or else change plans to keep their current provider without jeopardizing their HRA benefit by enrolling outside of VIA benefits. In comments for myself, I've submitted 2 additional public comments after the Tuesday morning deadline regarding board materials posted since Tuesday afternoon. First, in the draft changes to the duties, policies, and procedures, the formulas for setting rates by dependent tier and plan options are good to have there, but need to be further clarified. I have suggested some technical amendments that I hope you will consider. More importantly, the proposed policies on employer contribution percentages are really a reflection of how PEB values active employees versus dependents and retirees. The percentages have drifted over the years with little board input other than approving final rate tables. There needs to be a robust policy discussion. The employee-only CDHP plan should be subsidized by the employer at 100% rather than 93.5% because A, the health of employees is most important for their productivity in the state service, so it's an employer interest. And B, most cities and counties that compete with the state for hiring and retention provide 100% of the health insurance premiums for their employees, at least for a basic plan. It is shocking that the state of Nevada has the 5th largest number of full-time employees on Medicaid. Those are employees who can't afford PEB insurance for themselves or dependents or are better off on Medicaid. Helping generously with dependents is also important because employees need to take care of their families to be productive on the job and for recruitment and retention, given lower salaries from the state compared with cities and counties. The contributions for retirees represent a long-term commitment, at least for those hired by the state prior to 2012. Second, I submitted a history of the excess and deficient actuarial reserves. As of June 30th, there was a modest improvement compared with the earlier projections, but the reserves are still seriously deficient. The 2 to 3 year phase-in of premium increases that was implemented starting this fiscal year should start to correct that and add to reserves. Regarding the item on the fourth quarter budget report, it shows revenue at 74 million below the budget and expenses at 5.2 million below budget. But we know from the Milliman and Internal Review report published in April that the legislative budget was based on erroneous information provided by PEB during the 2025 session. So why hasn't the budget for FY 2026 been corrected through the Interim Finance Committee? Will the FY 2027 budget and future budget reports also be meaningless based on erroneous budgets from 2025? It seems like those ought to be corrected if you're going to use those budget reports for anything. Now, I would like to address the budget build enhancements in the elected officers report, which is the budget request for the next biennium. Bringing PEB into the Nevada Health Authority was supposed to provide efficiency gains, but now it appears that additional positions are needed. Whether those are feasible will be up to the governor and legislature. What is completely missing in the budget discussion are requests for the state to fund its share of the projected rate increases for the next 2 years. Board members, please approve the enhancements request only with additional funding requests for Aegis and Reggie to cover the shortfalls from PEB's fiscal crisis, which was not the fault of participants. Thank you.
Thank you, Dr. Irvin. Seeing no more public comment here in Carson City, move to online.
Looks like we have a couple online, Chair Wells. One moment, please. For those who joined for public comment, your name or the last 4 digits of your phone number will be announced, and you'll be advised you've been unmuted. Please slowly state and spell your name for the record, and then proceed with your comments. As a reminder for those on the phone, please press *6 to continue to unmute. Douglas Unger, you have permission to speak. Please slowly state and spell your name for the record.
Doug Unger, D-O-U-G-U-N-G-E-R, past president, UNLV chapter, Nevada Faculty Alliance, and member of the UNLV Employee Benefits Advisory Committee. I'd like to point out that we didn't get budget numbers or policy papers, proposals in time to be able to make coherent public comment. And I'd like to request of the executive officer and PEB staff that in the future, for members that you post these numbers in a timely manner so that we can submit appropriate public comment. Speaking to agenda item number 7, this year's increases in planned premiums paired with the cuts in benefits are really causing unacceptable financial stress for state employees. Now, further phased in 3-year and 2-year increases will be even more unaffordable. Last spring, the board agreed to discuss these plans again, and I hope that you'll do so. Board members should push back against any suggestion by the chair or others that PEB cannot ask for increases in employer and state contributions to Aegis and Reggie in the next biennial budget. If PEB's numbers last spring can be trusted, a 1-year increase of $90 per month for all PEB members would have stabilized plan costs without increases and cuts. For this first year of the new biennium, at least consider asking the governor's budget to meet state employees halfway with a 1-year contribution of half this hold harmless amount, or $45 per month per member, to reduce the stress and harm already being done to state workers. Speaking to matters discussed at the July 23rd strategic planning meeting, we're very concerned that PEB might actually consider separating active employee and retiree employee risk pools so as to raise premiums for non-Medicare retirees disproportionately by possibly more than 30%. And even worse effects would result if non-Medicare retirees would be separated from PEB and dumped onto the ever-eroding and increasingly expensive Silver State Exchange. To inflict on non-Medicare retirees radical increases in healthcare premiums, or for PEB to dump them, would be both punitive and wrong. Especially, this would single out state employees covered under the police fire statutes for PERS, our Nevada Department of Corrections, Highway Patrol, state police, and fire marshal officers, whose jobs are physically and psychologically demanding, and for whom PERS rules suggest our state should accommodate early retirements. The NDOC has a staffing crisis. Many of you may have read about the millions in overtime charges for the state budget needed to keep our correctional institutions staffed. This staffing crisis will get worse if officers are punished by cuts in anticipated retirement benefits. The approximately 3,900 non-Medicare retirees across our state have earned and deserve comfortable retirements. PEB should not break this promise to state retirees and, in effect, disparage and devalue their decades of service. Thank you.
Thank you, Dr. Unger.
Caller with the last four digits 9199, please press *6 to unmute. And please slowly state and spell your name for the record if you wish to make public comment.
Perfect. Sorry, it took me a second to unmute. Good morning, Chair and members of the committee. For the record, my name is Tess Opferman, that's spelled OPFERMAN, and I am speaking on behalf of the AFSCME retirees. I apologize for not being there in person today, so I appreciate being able to call in. First, I want to express concern for our retirees who are in Senior Care Plus and have recently lost their primary care provider due to the Kaiser changes. While I know PEB and VIA benefits do not have control over this coverage, you do have the ability to proactively support retirees through this change. As you are aware, if retirees change their healthcare outside of VIA benefits, they risk losing their healthcare altogether. They are allowed a one-time mistake. We are concerned some Medicare retirees may change their plan outside of VIA without realizing these potential consequences. We ask that you proactively reach out to retirees who are in Senior Care Plus and guide them through their healthcare options. Additionally, though again, this is being done outside of your control, this change is deeply problematic for retirees. Many received a letter giving them less than 30 days to find a new primary care provider. They will no longer be covered for their primary care at the end of August. Whatever pressure this board can apply to extend this timeline past the August deadline would be appreciated. Additionally, in the packet, you have provided a report looking at benefits for Medicare retirees versus pre-Medicare and non-Medicare retirees. I want to thank PEB for working on this report. I've not had the opportunity to fully review and digest this information. However, I'm hoping to get a better understanding of how Medicare Part B premiums were handled. The report says we have not incorporated Part B premiums in any of the analyses. Does this mean the report is short by a minimum of $205 per month that retirees have to pay? For context, the minimum of $205 in Part B plus $53 for PEB Dental, totaling $258, takes up all of the $260 HRA subsidy for those who receive the maximum HRA subsidy. Medicare Part B premiums are an important part of this comparison, so I hope to get more clarity with this presentation of the report. Thank you so much for your time this morning.
Thank you, Ms. Hofferman.
Chair Wells. That is all, Chair Wells. That concludes public comment.
All right, seeing no additional public comment, we will close agenda item number 2, public comment. We will open agenda item number 3, PEP board disclosures for applicable board meeting agenda items. Ms. Mooney.
Thank you, Chair Wells. Brandy Mooneyham, lead insurance counsel for the record. This item allows me to make a disclosure on behalf of board members who are eligible for benefits under the program regarding conflicts of interest. Consistent with NRS 281A.420, those members who are eligible or whose family members are eligible. On their behalf, I disclose that these members will be voting on items that may affect the benefits available to them or their family members or dependents. The law does not require abstention from voting merely because the board member or family member is eligible for benefits, as long as it affects everybody equally. At this time, I invite any member of the board who has additional disclosures to make that now.
Any additional disclosures from any board members? Hearing none, we'll close agenda item number 3, move to agenda item number 4, approval of the action minutes for the July 23rd, 2026 strategic planning meeting. Comments, questions, changes, motion for approval?
Jim Barnes, move approval.
I have a motion for approval. Can I get a second?
Laura Rich, I'll second.
I have a motion, a second, to approve the action minutes from the July 23rd, 2026 strategic planning meeting. All in favor, say aye.
Aye.
Any opposed, nay? Motion carries. Was agenda item number 4, move to agenda item number 5, the executive officer report. Ms. Carson.
Good morning, Teresa Karsten for the record. Today we're just gonna go over a couple of items related to how we closed last year and are starting this year. A brief touch point on the look back analysis that Siegel was asked to report on. Some budget build enhancements for the biennium 27 through 29. And then some RFP timeline information for upcoming contracts. So today I'd like to provide an update on PEB's fiscal year 27 starting financial position on the concerns that this creates for our reserve stability. PEB should have entered fiscal year 27 with a balance forward of approximately $149 million. That level of funding would have fully supported our first quarter operational needs and allowed us to maintain reserves near the $121 million level projected for fiscal year 26 for the IBNR catastrophic and HRA reserve accounts. Attached to the slide deck, you will find a version of the EMR report for program year 26. As you can see in this document, it shows by plan how revenue is received versus expended month over month. It also shows how PEB has historically relied on the balance forward amounts received at the beginning of every program year to utilize for operational expenditures until revenues are collected and amounts that can pay for the planned services. However, budget account 1338 began in fiscal year 27 with only $52 million. This is a substantially lower amount than anticipated and creates immediate pressure on our financial position. It might be interesting to note that 2 days ago, the slide said we would have a balance forward of $54 million. And our available cash looked like a balance of 1.1 rather than the negative 900,000 you see in the slide. However, additional expenditures cleared as part of final closeout this week, and this is what PEB's current snapshot looks like. Also for clarity, because we don't need to realize the $30 million shortfall all at once, which you've seen noted in this slide, we're not, as of today, negative 900,000. Therefore, today's cash on hand is approximately 29 million. I think we have some cash flow issues related to employer contribution groups that staff continue to reach out that maybe pay a little bit later than are expected. And so PEB staff knows that we need to track revenues and expenditures very closely, especially this year due to our stress on our budget. Reserve requirements at a glance. Siegel's actuarial determination of PEB solvency status is for the IBNR reserve to be $62.9 million. This amount is about 15.3% higher than the previous year. Currently, PEB does not have enough cash on hand to meet that reserve requirement. So as of today, PEB is not considered solvent at this time. Additionally, the catastrophic reserve level needed by policy is $53 million in order to pay the 45 days of claims outlined in the duties, policies, and procedures manual. And the 80% required for the HRA reserve is set at $5.5 million. It's important to note the discrepancy for the large reduction in the HRA reserve from last year to this year. Last year, when I started my employment with PEB, there was not a CFO on staff. And the staff at the time did not have the experience pulling reports from HSA Bank. I asked HSA Bank at the time for a report to help calculate the HRA reserve balance, and that report was provided included both HSA and HRA balances. Thereby, the calculation was inflated. Monica received this year's report, which was specific to HR balances only, and is calculated at the correct amount that you see here. As many of you know, PEB typically does not generate enough revenue to produce a surplus until November each year. This recurring timing gap means PEB begins every fiscal year in a constrained cash position, but this year's shortfall is significantly more pronounced. Furthermore, it is unknown at this time how the $30 million reduction in member revenue will impact the overall budget for program year 27. If member utilization increases seen during the last quarter of program year 26 remain, then expenditures could certainly be more than the current cash on hand, which would further reduce the available cash for reserve balances. I'm not certain solutions exist for this current program year, but as the board continues to look towards program changes for program year 28, I look forward to discussions and potential solutions. And I'm happy to answer any questions about these slides at this time, or we can wait till the end.
Chairman Wells, I continue to not understand the revenue, so is it counting on a cash basis? Is that, do we count for revenue on a cash basis?
Yes.
But we know, and I don't know the terminology, so you reference employers haven't paid yet, I think you said, so it's departments within the government, or that's people, that's groups that
Commissions.
participate, right?
Remember, Ms. Carson.
Monica, do you want, I was just gonna, Therese Carson for the record, I was gonna say so we get specific transfers from our state government, right, from central payroll, but we get other transfers from NG and the other various boards and commissions, and they don't always pay timely or in full.
And they don't always pay in full. Do they pay what they owe, or they pay less than what they owe? What's pay in full mean in this context?
They do not always pay. In some cases, they pay. So I think you can speak to this better than I can, Monica, but I think as we tracked in 26, in some cases they overpay, and in other months they underpay. And so there is a reconciliation of trying to make sure throughout the year that they end up paying the entire amount for their employees.
So I assume they owe a certain amount for the employees that they cover, or that the plan covers.
Yes, Monica McJoy for the record. So when we say pay in full, I bill you $10, you pay me $10.
Right,
You're
right.
paid, right? If I bill you $10, you pay me $8, you're not completely paid. So what we have noticed a lot is sometimes they do have turnover in certain positions, and some of them don't know how to pay the amount. They don't understand the formula. So a lot of times with the reconciliation process, we true up every month. So by the 25th of the month, if we're not paid, we do apply a penalty fee on that amount. But before the penalty fee is applied, we do reach out and let them know by the 20th, your payments need to be done. This is what needs to happen. And a lot of times we do understand that they don't understand the formula, and sometimes the way their funds work, they don't have them, and they'll send them at a later time.
I appreciate that response. I don't want to open that can of worms, because that seems like a whole nother conversation. But the $30 million, it's because we're at cash basis, it's represented as a deficit, but it's an accounts receivable also. It's money that's owed to us.
The 30 million?
Yeah.
The 30 million is the cost of the transition
Basic.
of the premiums. Where we didn't charge the full amount of the premiums to the employees because of the increase. That's the 30 million, correct?
Yes, that's correct.
So,
So
and to give you an example on the employer pay, so the university system pays their employees on the first of the month for the
Yeah.
prior month.
Right.
In general, you're supposed to pay your insurance ahead. And so they were, for years paying in arrears.
Yeah.
I believe that's been fixed, but that's an example of some of the things that we run into as far as employers not paying on timely things.
Teresa, would you mind going back to the slide that shows the cash, that slide? Just to help me understand, the revenue and balance forward is the July revenue and the cash carry forward from the prior year.
Correct.
The medical claims is just the month of July. The rate revenue shortfall is the full year rate revenue shortfall.
Correct.
So it's not,
Yes, that's what I was trying to explain. So we're not currently $900,000 short as of today, right? But we know that we will realize that $30 million shortfall over time. So our cash on hand right now is approximately $29 million.
does the medical claim figure also include the annual funding of the HSA balances? Does that have an annual HSA transfer?
Yeah,
No, the
The
transfer?
funding,
The-
is that an expense in that line?
No, that's not. So anything that's from the HRA, what we take is the incurred but not reported, that a pending amount that we get from our HSA account at that time. They say, hey, you have this many pending claims that's sitting out there. We include that in amount of any of our expenses, but the transfer is something separate.
So let me clarify the question I think he's trying to ask. Does the
Okay.
61.5 million
Less the
include
HSA
$14
expenses.
million or whatever it is in HSA contributions
Oh, yes.
that are sent to
sorry.
HSA Bank on July 1st?
Yes, sorry. I didn't understand your question, but that's true.
So so that is also an annual expense as opposed to a monthly expense.
Annual, yes.
Laura Rich for the record. My question is for Monica. How closely are you working with state payroll right now? Because I'm looking at my email and I have about 25 emails between my fiscal staff and state payroll specifically about this issue. And I think that it's a lot of people that are not involved, in the in insurance premiums and trying to figure out, what the rules are. And I think that PEP being involved in these conversations or being, more of managing some of these conversations might be helpful. I don't know if state payroll is very, I don't know how involved they are in this. So I'm just seeing this, from my department, which is, I believe, the biggest department in the state. So if, we're having this issue, I'm sure, it's probably problematic across the state.
So I try to be involved with central payroll as much as I can when it comes to premiums, any payments that we can possibly help them with. But when we're notified of certain situations, the fire has already been burning, right? So it takes time to fix the issue when someone fully doesn't understand. So I always try to be available and help out as much as we possibly can. So it's the constant emails back and forth that we try to be available to assist. But when you have a lot of, working with a lot of different groups or agencies that don't fully understand, it can be difficult on both parts. So I do always assist as much as I can.
Teresa Carson for the record, in addition to that, there have been on more than one occasion where we've reached out with GFO to coordinate and bridge that gap between conversations that we've had. Where either monies are owed or monies were overpaid or how to process and get additional information. And when we felt like we either couldn't explain it to the needs of central payroll or that we thought there was a gap in understanding, we did bring in our partners with GFO and have found, solutions. They're not always quick, but we have coordinated amongst agencies to try to resolve a lot of those issues. Other questions right now? Okay, go to slide 6. So in your board packet is the full detail of Siegel's look back analysis for program year 25. We've discussed this a little bit in previous board meetings. The plan rates have not been set to absorb the cost of expenditures. We talked about that before, cross subsidization, et cetera. The report shows additional information by plan, and if you have questions pertaining to the look back analysis, Siegel is available for any additional questions at this time or later during this presentation. I realize that, you know, you might not have had a lot of time to go through every page of your packet, but for any of you that have a current question, I can take those now before moving on to the next, which is my next slide is budget enhancements.
Tom,
This specific slide sorry, Tom, go ahead.
so the budget and the actual for 2025 is that 12 months of, is the
Yeah, that's 12 months of, sorry, Teresa Carson for the record. So this specific slide, as I understand it, is saying when we look back at what rates were set for 2025, were they adequate for what we actually received versus what we budgeted versus what the actual costs were, and what was the surplus or deficit? So did the rate meet the needs of the program? And so this slide is showing overall, over all the programs, we're about 35.9 million short for the rates that were set for plan year 25.
So referencing back to the earlier conversation, so the budget is the amount of money that we needed or required of employer. What was the requirement of each of these departments or employers to pay? Is that?
It was total need. So it would have included employer and member cost. It was necessary premium cost to cover
What
total
it was said,
expenditures.
if we got that, we would
Yep.
got 100% of what we.
Yep. If we asked for what we needed and got what we needed, then would we have hit our target? And this shows that we were short.
And that's short, how much of that short is that people paid 8 instead of 10, like underpaid, or how much of that? So this is purely revenue, right? This is not, there's no claims expense in here, anything, or
Well, the expenses are, the actual costs are based off the health plan claims.
the claims?
Yeah.
Okay. So how much there was potentially that the 27,000 that missed, 27 million that missed on the medical, is that we set the budget low?
So I think I think in theory, look back analysis is a great idea. I think we've had the last couple of years have been rough, right? Like we found a lot of errors in processes and systems. And so to your point, how much of this is somebody paid late? I think when we.
Let me try to help a little bit with what the look back analysis is, and Siegel can correct me if I'm wrong. 2025 is the last year that's closed because we have a 12-month window. So you have to submit a claim for FY25 by June 30th of 2026. So it is closed. No more additional claims can be processed for FY25. So this is really looking at how much did we bring in premium revenues versus how much did we spend in claims and administrative costs for a closed plan year. So when it says budget and actual budget for this particular purpose is not budget what you think. It's how much we set premiums to collect.
Yeah.
So that budget column is kind of a little bit of a misnomer. It's not a budget. It's the actual premium revenue that we collected for FY25 versus the actual expenses in the actual column that we spent for FY25.
I appreciate that, Chairman Wells. I'm trying to understand if first whenever you run anything, you have to have the revenue right. And that's what I'm trying to get comfortable that our revenue is.
So we knew in FY25 that FY25 was gonna run at a deficit. And FY26 and 27 were supposed to be set to restore the deficit that we created in FY25.
Okay.
Member Baton.
Also, just to try to make sure I'm understanding what is in our packet and what looking at. Where the slides refer to see Siegel report attached for full details, are those the pages that are later in the package that are after the presentation? So in this section of the doc of the package, there's some.
Yes, I
pages that
believe they
follow
got
the thank
included
you
as
slide.
attachments to this packet.
I guess that's just my question is whether that's the report or if there's.
That
another
is, it's like 10 tables.
And then I think for me, it's just trying to understand the relationship between, I know that this is a different period, this is FY 25, but the discussion about cash deficit, the deficit cash flow, and this slide, which is reporting that for 25, but comparing that, I think, to this page is part of the additional materials, the one I'm going to ask about. It's not in the presentation, but page 31 of the package. That is your monthly cash flow for FY 26. Has expenses that are less than that for the year, unless I'm reading it wrong. Page 31.
I don't have a page 31, so. What's it look like?
It's that table.
On?
That one.
And you're 26.
Yeah.
Oh, that's the EMR report. You're talking about the one with the green on the top?
Yeah.
Yep, that's the EMR report.
How does
And can
the
you ask
cash
your
flow
question
on that-
again? Sorry.
So I guess my question is, I'm helping me understand how the cash flow in this schedule fits into the discussion about cash deficits from claims exceeding revenue. Because this schedule appears to show claims being less than, unless I'm.
So the look back analysis is a closed period, so it's only looking at, did the premiums that we collected for FY 25 cover the expenses that we incurred for FY 25? The EMR report is more of a cash basis that starting in July through the period of June, how much did we collect versus how much did we spend? That's EMR is cash, correct?
So the EMR has multiple plan years in it because we're paying out prior year expenses. But we're also, we're collecting current year revenue, paying out current year expenses. So there is a mismatch between the periods, but it's still, so I guess I'm just trying to help myself understand how it fits into the overall conversation about how the performance is, because the budget report is that we're spending into cash deficit. But the cash flow report looks like we're not spending into a cash deficit. Unless I'm misreading it.
No, so
And-
FY 26 should have covered and started to restore reserves.
Okay. I may have.
So
a
that's why
different
that's
question.
why you're having just a surplus here in 26. And you should have in FY 26 or 27, when we do the look back analysis for 26, you should see that the premiums that we set are higher than the actual expenses that we incurred. Because that was the intent, was to start rebuilding reserves in FY 26. So you kind of have to look at these. You've got a cash basis report that says, here's what's going on month to month on a cash basis. You've got a look back analysis that just says, did the premiums that we set for a plan year cover the costs that we incurred for that same 12-month period? And that 12-month period isn't really 12 months, because you can have a claim for FY 25 that's not submitted until well into FY 26. So it's kind of two completely separate things.
Tom jumped up for the record. But are you talking about 25 we understand, but then 27 it says we have a $900,000 deficit, and then your cash report is, that's what
I
I'm
think
trying to
that is kind of
reconcile.
what I'm trying to understand, because I feel like our conversations have fairly consistently suggesting we're not building or pre-building reserves. That we've been deficit spending, the premiums were set too low, that we had to make the rate increases because we weren't restoring reserves. And I don't know if I'm misreading the cash flow report or if I'm misreading the other reports, because I just feel like the pieces aren't fitting together.
So from a
In that
cash
way.
perspective for the 12 months, that ended FY 26, we had additional cash. Whether we covered all of our claims for FY 26, we won't know till we do look back analysis. So we could still be in a deficit for FY 26 from a look back analysis, even though we have positive cash at the end of FY 26.
Laura Rich for the record. I don't know if we can get the look back analysis on the screen, but I have a question, probably for Siegel. We know what was in the budget. We know it was actual, right? And I'm gonna bring this up because it was the bane of my existence when I was in Teresa's seat. What PEB actually asked for is based on trend and what we get from the actuaries. But what is actually approved in the budget is usually not that. It's lower. It's a much lower number and applied through GFO. So my question is, if we had actually used what the actuaries had proposed, would that have been more on the actual, would that have been closer to the actual number rather than the budgeted number? Siegel. And I think my point here is that traditionally there's been a history of the trend that our actuaries provide does not actually get approved in the final governor's budget. It's a different number. And so maybe this is something that we need to start advocating for.
Debbie Donaldson for the record, DON-ALDSON. Thank you for the question. I'd have to go back and do the analysis to see what we anticipated versus what would actually happen to come up with that differential. But you are correct that historically the increases in the Aegis and Reggie had not been to the extent of what we've been utilizing for trend assumptions in the future.
But they were
Future
for
trend.
26 and 27. The legislature did approve the actuaries in trend rates for 26 and 27.
Okay.
So they are going forward, at least they did for this biennium.
Yes. So in this, but this is 25.
This is
So when it
25,
was,
so
This is 25.
Okay,
This is 25.
And then
Okay.
included at the full amount, but 26 and 27 were.
okay.
For the record, Debbie Donaldson, yes, my comments related to the plan year 25 look back analysis. And yes, you are correct, Chair West.
Any other questions?
Teresa Karsten for the record. 28-29 budget build enhancements. So PEB has a minor number of enhancements we've requested to assist in running PEB and achieving operational requirements under the Nevada Health Authority. PEB is requesting funding to fund 50% of a contract pharmacist and 2 management analysts who will provide vendor oversight of the state pharmacy benefit manager. Additionally, PEB has requested to fund 1 agency manager to coordinate procurement and accountability efforts with PEB's vendors and those shared with the Nevada Health Authority. The last 2 changes are minor impacts to the budget. They are requests to reclassify 3 positions to a higher grade, which will help with recruitment and retention of these operational positions. And lastly, if approved, our IT staff will move under the supervision of the Nevada Health Authority that has the knowledge and expertise to provide these positions in the direction of their work. This will be a cost savings as the Nevada Health Authority will pay for part of the positions, thereby shifting some of PEB's costs. The increased costs for these items are less than $1 per employee per month. Does anybody have any questions regarding this current slide?
And just to be clear, these will be discussed under agenda item number 7 for action.
No questions. Okay. These are some of the items that we discussed in last month's strategic planning retreat. I've outlined the priorities identified from last month's retreat. I wanted you to have these top of mind while I go over the timeline in the next slide for upcoming RFP procurements. As we will discuss later in the agenda during the contract status report, 6 RFPs are due to be released for procurement in addition to the 3 RFPs we wish to release in coordination with the NVHA. This timeline outlines the most conservative option to procure the contracts and implement the vendors to stand up on July 1 of 2028. Staff wanted the board to have a visual as you move toward identifying which contracts you wish to revise, as you discussed during the July strategic planning session. Large revisions to scope of work and unbundling some services from multi-contracts into single contracts will likely impact the budget. Contract changes that are not funded during the next biennium may have to be adjusted to be deferred until future funding is available. It may behoove PEB to extend through amendment some of these contracts to a later start date to assist with the staggering of procurements both now and in 2032. It's difficult to lift all of these at once. The agency and the board may struggle with these procurements and this timeline that we have available to us if we want implementation of all of these by July 1, 2028. Discussion on the timeline and procurements can occur today, but any future decisions on extensions not outlined in a later section of our board agenda will be brought back in September for possible action. Questions, comments around this timeline, or we can save it until we talk about it later. We can bring it back up later.
Any questions?
Lastly, vendors and board members are expressing interest in meeting with additional vendors to discuss possible alternative solutions to PEB's program costs and needs. It would be helpful for staff to understand if the board is interested in meeting with these vendors, and if so, for how many future board meetings before scope of work revisions are determined to be finalized. I don't need answers to this right now, but I just want to bring this up as we've been tasked with meeting with a couple of vendors, and if we're going to start talking about ways in which we can revise scope of works before RFPs, those considerations should probably really be seen at the board level, not the staff level. And with this previous timeline we've discussed, that's really short for how many you may want to select to see in your future agendas. So I just wanted to bring that to top of mind. And if there aren't any questions after that, that concludes my presentation.
Any questions? That is not an action item, it's an information and report. We'll close agenda item number 5. It's agenda item number 6 for budget report.
Good morning. We closed our budget at, as far as our income, we closed at 616 million. We projected last quarter that we were going to collect 603 million, so we did collect 13.2 more than expected. Any questions on any of the income? I do have it broken down, and I simplified it a little more so it can be readable. If you have any questions based on the income, you can ask them. You can ask me now, but I tried to be as transparent as I can possibly within this report. Do anyone have any questions on any of those breakdowns? And this also includes the $32 million that we did find with our audit that we did when we did find out that the calculations were incorrect. So this amount does include the money that we did discover. And you can see that in the state subsidies cell. So we did close with our income with 73 less than expected in revenue, but we already mentioned that the budget was uploaded wrong, so that's where you will see that deficit. Going down to our expenses, we did close at 563 million. It's less than what we budgeted for, which is a difference of 5.2 less than expected. If you go down to the bottom, it has the breakdown of the total budget revenue less the total expenses with the remaining balance of 52.5 million. Our actuary expected reserves was the 121 million. But due to issues, we are going to put the 52.4 into reserves, which leaves us under collecting the reserves at 68.7 million.
Questions?
And I just want to ask a question. Is this readable? Does everyone understand how these numbers are reported? I want to make sure that what I'm reporting to you is something that everyone can understand. So when I do the next budget report, that if I need to make any changes, I will take your recommendations and implement that.
Questions, comments?
Thumbs up, but for the record, this feels more readable than what I'd seen in the past.
Okay.
Comments, questions, any changes, future reports?
I'll ask a question. You mentioned the 32 million that was found in the subsidies, and just to help me see that in the reports, because you mentioned, I see it in the subsidy line. Do you mean that we would have been more under budget or over budget on the subsidy line?
Well, if we didn't figure out the calculations was wrong in our system, will be a lot less than what you see in column, well, I'm looking at my computer, where you see the actuals, it could have been 32, 34 less than.
So it's recovered in the actual.
Yes, it is. And our systems are set and everything is calculating correctly.
And I think that one of the things to look at as we're talking about the last one, where from a cash perspective, so the funds carried forward from the prior year, that very first line of 66.9 million, we're only carrying forward now 52.5. So from a total cash basis, we're still using money.
And I think that's really my question, going back to the cash flow schedule, because the cash flow schedule reported that for the year, we had positive cash flow.
It's claims. I don't believe that the EMR includes administrative or HRA or I'm talking about HRA for the.
I think it does. It does.
Does it include it for the Medicare retirees?
I don't, have to go back and check.
The EMR covered the Medicare.
It does. Yes, it does. It does.
So I realize, like, I'm not trying to reconcile it in the meetings, but that's my question is
Yeah.
I'm having
That's a good
trouble
question.
trouble fitting the pieces together.
Yeah, that's a good question.
We talk about
Debbie Donaldson, Siegel for the record. I believe it does not include for Medicare for the VIA benefits. Does not include the HRA for that.
That's what I said. It does
Yes.
not include the costs that are associated with so that surplus that is only for the plans that are run internally, HMO, EPO, PPO, PDA. Correct. So there are still expenses related to Medicare retirees that are not reflected in the EMR report.
And not knowing what that number might be, I just still don't know if it makes sense, because I think between the two, it's a delta of 31 million. So
It's a great question.
That's my question.
It's a great question to kind of dig into. Which yeah, you want to try and address it? So we're talking. Pause.
Debbie Donaldson for the record with Siegel. I think, you know, there's different ways to look at financial results. I think the bottom line that I think Executive Officer Karsten was trying to put forward is kind of what our anticipation is going to look like for plan year 27. We know that plans have been, there's a phase-in approach of which is an additional need of $30 million, which needs to come from reserves. I think the bottom line is that what she's trying to show with cash, with claims coming in, if they perform as projected, along with how premiums were set, and this additional $30 million that need to come from the reserves, plus funding your IBNR reserves, there's not enough cash on hand to be able to kind of, if all things play well, to cover some of that. And so I think that's the issue.
Let me try a different way first, and then if I don't get what you're after, then come back. So the EMR report shows a $17 million surplus for the 12 months that ended in June. This also, the report that Monica just went through is also for that same 12-month period. But it's showing that we went from almost $69 million to $52 million. So we used 14 million. We didn't gain 17 million. So where is the disconnect between what the EMR report is showing as a surplus and the budget report is showing as a deficit for the 12 months that ended June 30th? I think that's the question.
Because both are cash basis.
Because both are cash basis.
And in terms of the projection, you know, the premium increase that we implemented was because we were talking about deficits, period deficits in claims that were exceeding premiums.
How much did we have to?
So theoretically, we still would have had to increase premiums because even with 17 million, we would not have covered it, but.
I do appreciate that. I think
but you're right, but this is
concern
like,
is just,
again,
we're getting a lot of numbers
Yes.
and we get them in different
Yep.
ways. And as I'm trying to piece them together, I'm just having trouble with that. And I do definitely appreciate we can't do it in the meeting. We can't do it now on the spot.
Again,
there were questions.
But I think that it's a great question and it's something that we need to address and have brought back to the board at the next meeting.
Chair Wells, Debbie Donaldson for the record, agreed. And we need to coordinate and work together on how you're building the budget report compared to what we're reporting on the EMR report. And I take that as a takeaway that I'll work with the CFO, Monica, to help resolve.
Thank you. Any other questions? Hearing none, again, this was also an information item. We'll close agenda item number 6, move to agenda item number 7. Discussion of possible action regarding the framework for submission of the agency request budget for the 2028-2029 biennium. Ms. McJoy and Ms. Karsten are going to address this.
So, as we discussed earlier in the executive officer report, these are the enhancements that were listed. I know during public comment, it was talked about Aegis and Reggie. Aegis and Reggie increases have been built into the workbook. The final amounts have not been determined. Our goal, as we've worked with the Nevada Health Authority Department fiscal leadership to build our budget, is to present a budget that asks for 100% of our needs, right? The reserves that haven't been funded, all of the things plus these enhancements that we've listed here. When you put all of that into our workbook, it backs, plus our administrative load, it backs into new Aegis and Reggie amounts at higher levels. So again, those will be presented as an ask of what PEB needs at 100%. But we realize that it's going to be a very significant ask. And we've been advised that there's not a lot of state revenue that will exist possibly in the amount that we need. So what we're doing is also building decision units that would allow the governor's office and later state lawmakers to decide whether to reduce that request to fund our IBNR at 50%. And so I just want to be very clear, our ask is for what we need. That's how we're submitting the budget, not for what got voted on or what we think the reserves should be at, but what we've been notified through Siegel's report that we need to be solvent, plus a request to state employer contributions. Premiums will still rise due to the phase-in. And so we're still working through the finality of those workbooks and those numbers. They're not presented here today because they're not final. And they're kind of ever changing and fluctuating. But if you have questions in addition to what we've already gone over, we're happy to have that discussion at this time.
Tom Zelsbaugh, for the record. Can you help me to understand? I think you just said it, but so we're requesting what we need, and then that's based on, so it's for the next biennium for 24 months, right?
Yes.
And then it's based on premium projections already, or is it so is that premeditating what the premium increases are going to be to the members, or is it 100% of how do you what we need, how does that relate to what the employees would be paying? How do you think about
Yeah,
that?
so Siegel can speak to everything that's included in our underwriting tab, but it's similar to how we set rates, right? So historical claims cost trend, et cetera, that go into the rate build, right? I see Debbie getting up, so she's gonna explain it better than me. I'll wait.
Keep going, please.
And I'll try to simplify my question. So in essence, I'm new to the board, right? But a few months ago, we voted on what the premiums would be for the upcoming year. If they accept whatever we present, or in essence, is that also setting what the premiums will be for the employees for the next 2 years, because we're getting everything
So I think when Siegel projected what rates needed to be, and then we voted for phase-in, right? And so the underwriting tab for the budget build workbook should include everything for what the rates should be for costs. And then in addition to that, we have to ask for additional funding to make up for the $30 million shortfall and to rebalance the reserves, right? Does that help?
No, it helps. I understand. But in essence, we're saying those phase-in rates are the rates for the employees then for the next 2 years. If we ask for everything we need, it sounds like we're assuming that we're going to pass that cost on to the employees and get everything else that we need.
Well, part of so costs are shared between employees and state employers, right? So we're going to go in requesting additional funding from the state for state employers. But based on how we get funded will drive what the premium requirements for the members is, because we only get funded 2 ways, right? So if they don't give us what we need, then those go up. Yep.
Debbie Donaldson, for the record. The only thing to add is that, we're projecting out based upon what we know today for budgeting purposes, what we think is needed. And that doesn't necessarily mean those rates are going to be set in stone. Once we get more information, we'll
So-
relook at and do the
So
analysis.
we'll talk a little bit about how this works. So we said we have a biennial budget. So you're setting rates. You're submitting budget requests for 28 and 29. We just barely finished 2026. So you're almost 3 years trying to project 3 years out. So we're doing the best we can with the information that we have today to submit a budget a week from Monday.
Right.
During the next 6 months, probably no, not even 6 months, 4 months, we will look at it again and update the numbers. And then as we get close to setting FY 27 rates, or 28 rates, sorry, in the spring, those FY 28 rates will be pretty close to final. And so that becomes, the first year of the biennium really is approved by the legislature because they basically are approving the budget about the same time we're approving rates. But it's that second year of the biennium that gets to be a little bit trickier. And so the trend is built in, assumptions for trend are built in for both years of the biennium. Additional funding to recover the reserves are being built into the budget request. But we're gonna have to be super clear about what that means, because I think that when the board set rates for 2026, from what I saw and read, there wasn't really a discussion about the money that was being added by the legislature to replenish the reserves. It was just a discussion about what are the employee rates and what is the breakout between the employer and the employee.
Yeah.
So we're gonna have to be cognizant that as we set rates, that we are setting rates that rebuild these reserves with any additional funds that are being provided by the legislature specifically for that purpose.
And that's exactly what I was asked, Chairman was, that's why I was asking the question, because we could approach it. I wonder if we could approach it that we truly ask for everything that we need, which means we ask the state or whatever terminology is, ask the legislature for all the money we need to fund it at 100% based on the rates that the employees are paying now, not assuming that we're passing on new costs to the employees. And then at that point, at least the legislature knows the whole picture. And then they could decide how much they give us, and then we set premiums after that. But I feel like when it's chopped up like that, it doesn't get the whole story up there. And so I feel like if we're asking for everything we need, we should ask for everything we need. And then just like you explained to me, whatever they don't fund, then the only other place for it to be funded is on the employee. But when it's asked in segments, I think the whole, and I don't know how you ask, but I feel like we should ask for everything we need from them. And then they're making a decision that they're passing it on to the employee.
So part of it is we will, and then this, the kind of the next piece, the subsidization policy is how we split that between employees, retirees, and state subsidies.
Right.
And so how is the employee gonna pick up 7% of the rebuild reserves? Or are they gonna pick up 7% of the premium and the state's gonna pick up 100% of the reserves? Those are still discussions that will have to be had between policymakers at the legislative level.
No, I agree. And I'm starting to understand that a little bit, but
But the ask is intended over the biennium to restore reserves. The additional funding that we need to restore reserves. And then we're gonna have to, as we look at the plans and the subsidization policy next, that still will go into how much the employee pays versus how much
and I agree with the Chairman Wells, and then to restore reserves, in essence, it's kind of terminology also, right? Because you're really asking for enough money to fund the plan. And if they don't restore reserves, or if they, it does, and so it's almost like the budget conversation we had a few minutes ago, there's a lot of moving pieces. And what I'm asking is maybe we should ask without a lot of moving pieces. We should ask for what we need and then explain later versus asking for pieces.
we will. It's being built that way. So any additional questions on these 1, 2, 3, 4 administrative enhancement requests? If not, I think we'll make a motion individually, not individually for the four unless we'll require it, but for the administrative enhancements, we'll take as a single item, a motion to approve these four enhancements.
I'm good. Motion approved.
I have a motion to approve the four individual administrative enhancements that were laid out by the executive officer. Do I have a second?
Laura Rich, I'll second.
A motion and a second to approve those four individual enhancements. All those in favor say aye.
Aye.
Any opposed, no. Motion carries. All right, let's move on to 7B, the state subsidization policy. And that is what is laid out in the appendix to the board's duties, policies, and procedures. So starting on page.
I think Monica was going to go and start. No, are you changing your mind?
All right. Ms. McJoy.
Okay, so anything that's marked in red was updated. This does show how the plan is broken down. Also how we have entered the G, which is the general overhead cost, which is going to take care of all of the administrative costs for the PEB, considering the personnel, the IT, and all of the expenses that comes with operating the budget. This breaks down how those costs are going to be broken down amongst all of the categories of all the tiers. That's what this shows, the breakdown of the general cost with each tier.
All right, before we move on from there, let's make sure that everybody understands how this works. Are there questions? Do we need to clarifications? All right, I have one. I can start with one. So when we adjust the rates to reflect when we set rates for this current plan, this is probably for Ms. Donaldson. When we set rates for the current plan year, we set rates for the CDHP, the PPO, and the EPO kind of separately. So how did we do this adjustment by plan in the current? So one of the things that this is, the document that's here is reflective of what was actually done for FY27. So it's not necessarily what we should have done or what we should do in the future. This is what was done for FY27. So let's just be clear about that. And so we just need to make sure that this is how we want to do this going forward. So can you explain a little bit about how we got from the individual plan costs?
Debbie Donaldson for the record at Siegel. So the first thing we look at is the percentages is based upon the CDHP. So we were using 6.5% and we look at the employee only.
No, not that part. How we calculated the whole the entire premium.
Oh,
not
the entire premium, sorry. So when we calculated the entire premium, we, for plan year 27, we looked at the phase-in component and what was needed. So what we did look at is we said, okay, what would the total rate look like? And then how much we are getting from Aegis.
No, I don't want to, I want
sorry.
to, how did we get the total rate column? So the very first column on the rate tables, it's the total rate that we pay for employees, spouse plus children plus family. How did we derive that for the CDHP and how did we differentiate it for the other two plans? How
So
did we calculate those
Oh, you mean the
total
different,
rates, the total rates, not the ages, not the state's portion or the employee's portion. How do we calculate the total rates for the three plans?
yeah, so there is a factor, and there are a couple components to that. And again, this is based upon a model that I think has changed a little bit since I had worked on it in my previous employer. But what the total rate is done is it looks at the looking at the medical and pharmacy claims. So the employee only, and then the employee plus spouse is twice that. What ends up happening is some of the life insurance and disability gets added on then after the fact. So if you're looking at the ratio, it's not exactly, for example, if you look at the employee spouse, it's not exactly 2 times the active rate. It's something a little bit different because of the adjustments for life insurance and stuff that are added in after the fact. And so there are different factors for the employee plus spouse, the employee plus child, and then the family based upon that employee only rate. And it's the same factor that is used for each of the plans.
But what was the underlying basis? Maybe I don't know how to ask this question the right way. What was the underlying basis to calculate the premiums for each of the three plans? The claims that were associated with those individual plans? Was it a factor from one plan to a different plan based on actuarial value? Was it based on strictly on the cost for the individual plans? How were those three planned total premiums calculated?
Debbie Donaldson, for the record, we looked at the claims for each of the different plans, correct?
So they are not necessarily a single, not looking at it as a single group of people and then adjusting the other two plans from a single pool. It's setting the rates individually by the costs that were incurred by the three individual plans.
Correct. And we were adding in some of assumptions associated with, again, we're looking at rates, historical rates, and then projecting forward. So we did add in some assumptions as far as migration and who's coming in, and adding some risk adjustments to that, to some of those plans to account for different kind of risk pools that we're anticipating because of the change in the rates. But yes, each of the plans was looked at, and the claims were separately looked at and rated with some adjustments, correct?
One second. So if we looked at our total population, the claims of our total population, and did adjustments based on the actuarial value of the three different plans, what would that look like?
Debbie Donaldson, for the record, that is a little bit of the approach we're coming out of, right? Because certain plans are subsidizing other plans. And so in aggregate, the pool is, the claims are the claims. It's depending upon who's paying and who is paying for the portion of those total claims. And that's why we're seeing the big increases, because we're getting rid of those subsidizations, if you will. And that's what's generating, at least for plan year 27, 1/3, which is about $30 million of additional funding that PEB is picking up, and not the members. And so we're looking, but the pool is, the claims are the claims, it's just how we're reallocating that. You're correct. And we could do it by actuarial value, but then again, the plans are going to be subsidizing each other. So getting back to the point where the consumer-driven healthcare, most notably, is subsidizing all the other plans.
And then the calculation for the children tier. So I believe, in looking at the workbook, that it is
what the ratio is.
Yeah, I don't remember now.
It's 1.375 of the active.
So
rate.
the children, the thought here is that the children cost 37.5% of the total cost of an adult. The aggregate cost for all children is 37.5% of the adult population. Do we have data to back that up?
Chair Wells, for the record, I do think it may be prudent. Yes, we do have data. These factors have been in place for a long time. The factors of, so employee plus spouse is 2, employee plus child is 1.375, family is 2.375. These factors have been in place for quite a while. I do recommend that we take a look at the data. It's not just a couple of years. You have to look historically at like 5 or so years to make sure that you're looking at it appropriately for a risk pool, to make sure you're just not reactive to like the last year or two. Exactly. So I do recommend that we take another, because it's been a long time. These are the rates that I used 10 years ago. So I do think it is prudent for us to take a look and potentially readjust those.
Okay.
And or to confirm and validate that these are appropriate for the tier ratios. Otherwise, to your point, Chair Wells, what ends up happening is different tiers are subsidizing each other. The total rate won't change, but how you allocate it between each of the tiers could potentially change. And I'm just throwing something out. Depending on how the factors flow out, the employee only may be subsidizing tiers for the family because maybe the family is higher. Just throwing out an example. So it would make sense to take a relook at these.
And then the last question I have is on the general overhead costs. And when I talk about general overhead, I'm talking about the PEPM cost that we pay for all of our vendors. I'm talking about the salaries and rent that we pay for the staff. Those costs now, according to what I saw in my review of the work, I'll just be honest, I've seen the workbook, are now not individual are not the same for every tier. They are based on the number, and it's not necessarily the number of people. It is based on the same ratio of the four tiers. So the administrative costs are not the same for every tier. They are different for every tier based on the tier ratios that are outlined. The single person 2 times for plus spouse, 1.375 for plus children, and 2.375 for family. So all those administrative costs now are being proportionally driven based on those ratios. Is that correct?
Chair Wells, Debbie Donaldson, yes, that's my understanding as well. And when I look at the rating, and it previously had not been like that, correct? And so at some point there was a change, and it is, so essentially when you're doing that, you're creating a little bit, right? Administrative fees are a small component of the overall cost, but yeah, there is some cross subsidization, correct?
Well, and it may be a little bit bigger if we depending on how the reserve replenishments are built into these rates. If you build them in as an administrative component, if you build them in as part of the administrative component, how they would be appropriate, or how they would be proportioned would be different.
Correct.
So that means that when you look at that table at the bottom, it's not 2 times X plus G, it's really 2 times parentheses X plus G. And then there are some outliers so that we do not do the life insurance is not included because it's only for the primary employee, and we don't have LTD anymore, but LTD was separate, and so was the small administrative cost related to the Medicare retirees was separate, I believe, from the
correct
administrative overhead.
You are correct.
So there's basically 2 times the X plus G, then plus you've got the life long-term disability, and then the cost related to the Medicare exchange.
That's correct.
So that would need to be both defined and updated in this table before we.
Correct.
Other questions, Commissioners, on the vote?
Chairman Wells, I'd like to understand the answer to your original question. So what I heard you trying to ask is, do you start with all of the claims in a pool and then you apply some factor by plan? Or is the pricing based on the experience by plan? And I'm not sure what the answer was.
The answer that I think I got, and Ms. also can correct me if I'm wrong, is it is the cost by plan adjusted for what they believe to be migration in and out of the.
So the
various
basis,
plans.
so like, because I leaving migration aside for a moment, the basis would be by the current experience by plan.
Correct.
Correct. Debbie Donaldson for the record, yeah, each plan is individually rated, looking at each plan individually, correct?
Because that was the question, or that was the issue we were trying to address at one point, was that the CDHP, and if you look back at that surplus that the CDHP was driving, was basically used to offset the deficits in the other two plans. So the idea was, let's set those plans reflect what the costs of the plans are, so that the one plan is not subsidizing a different plan. So
Yeah.
I mean, it's all, this is a policy issue. That's why we're having the discussion.
It's important, and I liked where you're going with the question. Because I think if it's pooled. And it is a policy discussion, right? But if it's pooled, then it does, I think, at least take into account the cost, the high deductible health plan very likely attracts a lower risk. And if you're pricing it against itself, it's always misleading, to some degree. But if you pool it all, I think you mitigate some of that. Or you're the expert, how would we mitigate that?
Debbie Donaldson for the record, thank you for the question. So there's different ways, and I'll say states choose different approaches. In the past, what has happened is the CDHP plan has subsidized the other plans. But we haven't gotten enough money from those other plans to help cover their costs, even with the subsidies, because we're doing it just on actuarial value. And so what we're doing, starting in plan year 27, and what we've been looking at is because the risk pools in themselves are big enough on each plan to stand alone.
Okay.
And so, at least as of now, to stand alone. And so we're rating those plans separately.
No, and it's always tricky, but the result that we're getting with the high deductible subsidizing the other plan is not a surprise. Because it's a lower premium and it attracts better risk.
For the record, Debbie Donaldson, you are correct. But however, what ends up happening is behavior economics come into play. So I'm a member in the consumer driven health plan. Golly, I know I have to have my knee replaced. I'm going to go to the low deductible PPO plan because I could pay, a different amount, and my out of pocket's going to be the same, and I may get, better service because I just have copays versus I have to pay these upfront deductibles and stuff. And so it does create different financial outcomes with the plan when you do this kind of subsidization. And so we've seen that particularly in the EPO HMO plan, where all of your higher risk is in that plan because it's a more generous plan. And so we presented, I believe back in March, when we were looking at the risk scores, right? The risk scores are much higher in that EPO HMO compared to the other plans, to your point. And so it does come down to how PEB wants to rate these plans, if they want to be separate, individually stand on their own. And so the members in that plan are paying the cost for that plan. That's a decision to be made. But starting in plan year 27, that's the path that we're going on, and looking at each plan and then making the members in that plan pay for the cost associated with those plans.
And it's also, Tom's on top of record, because it is behavioral economics also, and it's an annual enrollment, not a month-to-month enrollment, so they'd have to plan, they can't just move because they're gonna have a surgery, but they could plan for a pregnancy. There's a lot of opportunity for them to do it differently, but the high deductible, my point is, I think the high deductible is an excellent plan for certain people. And it also is valuable because it does attract good risk. But that's potentially part of the policy is that it actually does subsidize others. Because if we moved everybody into high deductible, the high deductible would not perform as well as it's performing now. It's performing well because it has healthier people in it.
Blue Ridge, for the record, I also want to add that the high deductible plan is the default plan as well. And so if someone does not choose plan, they get put into the high deductible plan.
Which are the people that are less, or that are healthier, or the people that I'm not saying, something needs to be on the table in this discussion. We can't just assume the high deductible is running better than other plans. There's reasons that it runs better than other plans.
There are. But I mean, looking at, part of it is like the copays related to prescription drugs. You're gonna take prescription drugs. Well, instead of paying your total out of pocket on the CDHP, it's way better to pay a copay, a $25 a month or 90-day copay. So you see a lot of it driven by that kind of mentality too. That's the kind of behavior economics is like, I have to take this drug now and I take it for a long time. I can pay the whole cost over here, or I can pay $25 over here. And so you see that kind of shift too. So we need to be careful of, when we set the plan designs, that we're not encouraging people that take this expensive medication to go where it costs them little, but the plan a lot.
Yeah, I agree, Chairman Wells, there has to be a balanced approach. And it's the reason that I asked for clarification of your question, because the basis of how the very foundational basis of how the pricing is critically important, right? And it kind of ties back to what I've heard you say in previous meetings, kind of right sizing the funding. You got to start at an initial point of everything is to some degree the same, and then you make decisions about how you affect it no longer being the same, either by driving different utilization or charging premium, right?
And so when we first kind of went to this model 16, 18 years ago, a long time ago, we only had one self-funded plan. The other two plans were fully funded HMOs. Now we have 3 self-funded plans and, or 2.5, let's call it 2.5 self-funded plans and a half HMO. So we've got a different plan mix. And I think that we have been struggling as an organization since the inception of the middle plan to kind of come up with equitable distribution between these now 3 plans. I think that's where I'm really struggling with this is what is that equitable distribution between these now 3 plans?
Yeah.
And I think that's where the board is struggling.
The foundational piece, I agree.
Can I just, not being an actuarial expert, can I just reiterate, and I want to make sure my understanding is correct, so tell me yes or no, and then I have a question. So what I'm understanding is the problem that we were trying to solve for here is that we had a lot of cross subsidization, like one plan essentially subsidizing the other. And so moving to this policy is essentially returning that cross plan subsidization to 0. Yes, right? We're not subsidizing to plans now.
Debbie Downs, it's to get to 0 over, I believe it was approved 2 and 3 year period, depending on.
So essentially to remove that subsidization.
Yeah.
Okay. And then, but what I'm seeing as amongst, I'm sure others, a potential risk is that there now could be subsidization within the plan between the tiers. So that was correct. That's what I was hearing. Okay.
Debbie Donaldson, for the record, that's correct. These tier ratios haven't been analyzed in quite some time. And so we need to, I do recommend that we take a look at that to see if there's how these tier ratios stack up to given the most recent kind of 5 years worth of historical data. Yes.
Yes, because that was definitely my question is, have we modeled what that would look like between each of the tiers? And sounds like that's something we do. Okay, got it. And then to the point of reducing that subsidization over a couple years, and I know we were looking at decreasing, you know, moving around the values and such. Would instituting this policy in this now, does that account for the fact that we are slowly moving essentially to this, or would instituting this policy immediately drop it to zero? Or are we able to, you know, this is the policy that we're moving towards?
Well, we would still have the implementation or the phase-in approach that the board approved,
Okay,
whatever.
so that phase-in approach would still apply despite making this change into the policy?
And we're not gonna, I don't wanna approve this actual piece today because I think this part still needs some work. I think having the analysis of the children tier that Ms. Donaldson was talking about needs to be done. You know, and I think if you read Dr. Irvin's second public comment, you know, we used to have tiers, the plus spouse was more expensive than the family, so it was actually, you had a kid, your rate went down. Because what happened was the people who had kids were typically younger adults. The people who were in the plus spouse were older / retired adults. So you had some really weird fluctuations between tiers that didn't really make sense. And so we kind of went to this tiered ratio of adults, 2 times adults plus children, and 2 times adults plus children. And then that has kind of morphed over the last, well, how many years? And I think that the board has not approved this policy. So my point in putting this in here is I don't know that the board knows what the policy is behind how the rates are being derived right now. And so how we're getting to these X's and A's, how we're multiplying the numbers, the tier ratios across plans. I don't think the board knows exactly how the rates are being set now. And I think that once you put this in policy, setting rates really becomes a math problem. It's not really we don't get to pick and choose and based on the outcomes. We pick and choose based on what the math says. And so while we still probably need to have some more discussion about this, I wanted the board to know we need to have more discussion about how we set these plan premiums and how we analyze the difference between the tiers and how we allocate administrative costs. All of that stuff is a policy decision that if you do it the old way, where the administrative costs were all charged based on the primary pays a little bit more, all the other tiers pay a little bit less. When you allocate it based on tier ratios, they pay a little less and all the other tiers pay a little bit more. So there's all these fundamental questions about how you do this that drive the tiers. And then the next part that we're going to discuss is how we subsidize those, how much the employee pays versus how much the state pays. And that decision we do need to make today, because that is a key component in how the budget is built. Because the budget basically splits it between how much the state contributes and how much the employees and retirees contribute. So that ratio for the next piece does need to be decided today. But this piece, I wanted to have this discussion so that we can figure out and bring it back. And what does this table really look like and what does it really mean?
Yeah, no, I agree that I think we should have some more financial modeling to be able to see that.
Yep.
I have one, sorry. No, go ahead. Okay, just one very specific question. How are the general overhead costs allocated? Is that like a flat by enrollment or like how is that defined?
Go ahead.
Go ahead.
It's allocated by the tier ratio. So the general administrative costs are divided by a multiplication of the tiers times the ratio, the number of people in the tiers times the ratio, aggregated and then divided back out.
Oh, okay.
And so it basically says if you are a single person, you pay one general overhead cost. If you have a plus spouse, you pay 2 times that overhead cost.
It's a very complex Excel worksheet.
Yeah.
Okay.
Yeah, tell me about that.
Which is not defined in here, otherwise there would be some parentheses, I think.
Yes, and that's why I say this is,
Okay.
that's why I say this is actually
Okay.
not correct.
I was like, there's an order of operations that you would have to.
It's gotta be 2 times parentheses X
Yes,
plus G.
that's what
not-
it is.
Exactly.
Not X 2X plus G.
So
Miss-
Laura Rich, for the record, I don't know if this is part of this part of the conversation or the next one, but I was thinking about, and Jim, you mentioned it, where before we actually, the rate for employee plus children was sometimes less than employee plus spouse because the spouse is typically more expensive than the children are. But I was thinking about it this morning, and we have a rule at PEB that if your spouse has access to coverage elsewhere, they cannot be covered through PEB. The problem is that how do you enforce that? There's no way to enforce that. So, I know plenty of people who have added their spouse even though their spouse has access to coverage elsewhere, just because, despite what people say, the PEB plan is probably cheaper than what is out there, in the private sector. And so it's cheaper for them to add their spouse than it is to have their spouse covered through their own employer. So thinking about that, is that something that, we can encourage through this policy, right? Like how can we kind of enforce our own rules that we have, and potentially if people have coverage elsewhere, encourage them to seek coverage through their own employers, their spouse anyway, so that we can then, we have limited funds. Again, we've had this discussion, we have to be able to focus our efforts on whether it's the employee, whether it is active versus retiree, all that stuff. And so maybe this is a way to enforce our own policy and thinking about that. So I don't know if that's part of this discussion or if it's the next part, but it's something to think about.
We have talked about a little bit in the past, doing a dependent audit. So basically we confirm whether the dependents are eligible to be on the plan or not. And that's one way to do it, because the other thing you see,
Right.
Anecdotally, I don't know that I know this, is that if somebody gets divorced and instead of having to pay for the divorcees or the ex-spouse's insurance, they just keep them on. And so, we don't necessarily catch that because they have to tell us that they're divorced and that they want to remove their spouse, and they may or may not do that. And so yeah, doing a dependent audit will probably catch some of those people that shouldn't be on our plan anymore too. Okay, so we're gonna bring that part back. The second component is on page, that's not in color, starts at the bottom of page 21. Subsidy percentage, which is the percentage of the premium that is paid by the employee and or the retiree, and the amount that is paid for dependents. And so it talks at the bottom, the active employees, and this is the percentage of the CDHP, 6.5% of the CDHP, plus 31.5% of the dependents. And again, this is another formula that is pretty complex. Used to be a little bit more simple of a formula, comes out roughly the same. And then on the retiree side, it's 30% and then a 25% differential, so it's 55%, they pay 55% of the dependents. And that is for a base retiree. So that is for a retiree, pre-1994 retiree or a retiree with 15 years of service, and then it's adjusted up or down based on the years of service. So to be clear, the 60 or 30 and 55% are adjusted up and down based on tier. These are different than what I remembered, and we had a public comment about, do we have a $0 plan, a base plan with a $0 premium for the employee, which means that we would cover 100% of the CDHP. I will say those local governments that do that typically don't cover their dependents at the same percentage that we do. So would you, do you offset that with a bigger differential between the dependents and the active person if you do that? The other thing, and it wasn't really supposed to be put in here, but it got put in here anyway, is kind of, if we're setting these subsidies based on the CDHP, and the CDHP's trend is lower than the other two plans, the PPO and the EPO, that subsidy is not going to go as far if you keep the same subsidy for all three plans. So that those other plans are going to continue to get more expensive as long as those trends on those other two plans outpace the trend on the CDHP. So that's just another consideration when we talk about this is that you're going to continue to, if that differential in trend is continues to widen or continues to be wide, the subsidy is not going to go as far, and those other plans are going to continue to get more expensive for the employees than the CDHP is. So that policy that would need to be part of this policy if we wanted to change that for the other two plans as well. So this is kind of set it as it is. So we subsidize 6.5% for the, or we 93.5% we subsidized for the employee only, and we subsidize 78.5% for dependents. And then for a retiree, we subsidize 70 and 45. So are those the right percentages? And then should they be the same across all three plans? So open it for discussion. One. Never done.
Keiko Duncan for the record. So, if these, okay. I'm gonna skip a bunch of other questions I have. So say we set the set rate by, member type essentially. And it's a flat rate no matter what plan they're in. Okay. What happens if that subsidy doesn't keep pace with plan costs? Like is there something that we have to analyze on an annual basis to ensure that it is proportionate or appropriate to plan costs?
Debbie Donaldson for the record. We're kind of seeing that now with your phase in, right? So you're trying to phase in the approach from where you are today, right, to get to the true costs. And so, yes, it would have to be reviewed probably annually if you decide to go with a different methodology than you do today. And again, just to reiterate, everything's set based upon the subsidy, the state subsidy, if you will, is based upon the consumer-driven healthcare plan. And it's the same for each, and it's set kind of starting with the biennium and what we're projecting. And so if the money that we're gonna give, and then I guess it depends on how that gets allocated.
So have we seen these, well, have we modeled this yet, these numbers? Have we done like a financial model of what that would look like on the premiums and
Well,
such?
this is what we use for 27.
This is exactly what we.
This is what we use for 27.
Got it. Okay.
That's why we put it in here. This is what was used for 27.
Okay.
Right, wrong, or indifferent. It's what was used to calculate the employer split.
Got it.
Teresa Carson for the record, it's also what was programmed in our workbook for the biennium.
For the budget, yeah.
Correct.
So Laura Rich for the record. So first of all, I mean, I do have to say that we got this report late yesterday. I have not had a chance to read it, absorb it, so that's a little bit of a challenge in itself. And I have lived and breathed this stuff. And so this comes a little bit easier to me than maybe some of the other board members. So I think just in the future, we really need to be able to get these reports well in advance to be able to have these kinds of conversations. But my other question comes back to my last comment is, can we separate the dependents and maybe subsidize employee plus children at a different level than employee plus spouse, et cetera? Like maybe take a look at that, or is it just dependents or dependents?
To me, that's a board policy. If the board's policy is to subsidize children at a higher percentage than adults, you can build that into a formula. This is all just formula driven. That's why I say at the end of the day, this narrative that's in these 2 or 3 pages equates to additions and multiplications on a table.
Again, it comes back to, we have a policy that we can't enforce, and I understand we have a dependent audit, but we have to pay for a dependent audit. It's very disruptive to people, which is why it hasn't been done in the past. But if we have, if we encourage it through, our pricing, potentially, we can enforce the policy that we have.
Questions from other board members? Any questions from board members online?
So, Kay Duggan for the record. So are we saying that this is what we've done today? So we're just building it into policy for transparency's sake, and we are using it as a starting point to build the premiums and the rates next year.
Next biennium.
Next biennium. Okay.
Yeah,
With-
I thought it was important that the board sees what it is that we're actually doing.
Yeah.
Because I think this policy, when we created this a long time ago, that was the idea. Is the board said this is the policy for setting rates and subsidizing them. And the rates were brought back in a manner that did that. Now you see that the rates are kind of brought back. We're not really sure what these numbers equate to. We don't see that. And so the idea behind this was this needs to be approved soon. Because we need to finalize the governor's recommended budget. So the agency request is being submitted with these percentages in them. Because it's way too late to change the workbook and change the budget at this point. But we can change them during the GovRec process to reflect a different policies, but that policy still needs to be approved soon. So you can approve it in September, but probably not really much beyond September.
But it sounds like that, if we need to evaluate it annually, like Debbie was saying, that our policy needs to reflect that this is only a starting point that would then potentially change annually or biannually, whichever.
Debbie Donaldson for clarification. It depends on how it's set, because you were saying if we're gonna change it, I think the question was if you were gonna change the allocations by different plans and it's based upon a percentage, you would have to look at it to see how it's trending year to year to maintain that same kind of thing. So differential. So it depends on what you, as the board set as a policy, if it needs to get reviewed every year or not.
So Laura Rich, for the record, Chair Wells, would you say that this is really a conversation about prioritizing, the board prioritizing where we think the subsidy should go?
Yes.
Actives versus family versus spouse versus retirees. I think that's the conversation.
That's the policy that's the policy that according to this document needs to be recommended. Now, the legislature can still change it if they wanted to. But that's what this says. I mean, at the bottom of page 21, the employer subsidy percentage will be recommended by the board to the governor during the agency request phase of the biennial budget. That's where we are for the next week and a half. And so if we don't do anything, I'm showing you that this is what is in the agency's budget request. If we want to make adjustments to that, we can. We just need to make them soon.
So Laura Rich, for the record, I think where I'm struggling is I see the numbers and I know where my personal opinions about this, but I would like to know, what are other states doing? What are other plans doing? How do other plans really, how's the county doing? Because that kind of drives what is the standard, right? Is the standard to subsidize retirees at 55%? I don't know. So I think that's where I'm struggling. I know my personal opinions about some of this stuff, but I would rather not make my decisions based on my personal opinions.
So a lot of the local governments prioritize the employee. So their employee subsidization percentages are higher.
Right.
Their dependent subsidizations are lower. And their retiree subsidizations, if they have them, are lower. And you know, if you talk about other states have done different things. I mean, this is almost employer specific. It really is it would be very difficult to say all the employers do. You could do some averages maybe, but I think that in general, I think that what you see is the prioritization is employee first, dependents, and then retirees.
And I do think that from a recruitment perspective, we have to think about that because that's who the state is essentially recruiting against, right? And you know, we already have significant, you know, salary differences between the local governments and the state government. And so now, you know, we've got to look at this piece of it as well.
And you could set this for active employees at 0 for the CDHP. That doesn't mean it's going to be 0 for the PPO or EPO. It means they're still going to have a premium that they're going to have to pay out of pocket for the employee share. It would only be that the CDHP would have a $0 premium. So you could do that. We haven't for 28 plus years. We did at one point. At one point, employees were free. But at the end of the day, when you try to subsidize everybody, there's only so much money. So it's really about how you move that. What's the policy on how you move that money around? And that is one of the things that this board has control over. So we can do this. We can take no action on this today. The budget would be submitted based on this because this policy is what's basically in effect for 2027 plan rates. So this is what would be submitted with the budget. If we want to change that, we need to change it soon. September is the deadline, or it's actually October 2nd. We just moved that.
Yes.
So October 2nd, the next meeting, this needs to be approved. This policy needs to be updated and approved to be reflective of what the board's position is relating to establishing rates and subsidies.
I feel like I've been fairly vocal about, you know, my where I stand on, you know, some of these issues, but I would like to hear what the other board members feel and, you know, if they have any thoughts on this.
Any other comments on this?
What Tom's talked about, for the record, I first agree with board member Rich about just seeing it last night and trying to digest it. But with that being said, I don't know if I would feel any different with time because I don't have too much of a basis of comparison. And so as you're talking, which I really appreciate this conversation about have to make a decision next month, which seems very fair. I'm not sure what to ask for to make me have more information now than I would have, more information next month than I have now. And I don't know if you might have ideas on what we might have. I heard what you said that, you know, kind of roughly thinking about our competitors, but I do think to me, there's a significant recruitment and retention conversation that I don't work in your environment, so I don't know, you know, but it seems like that has to be part of the conversation.
And unfortunately, board member Grimmer, who she oversees the Department of Administration. She's not here today, but that would be, you know, good insight to have. I think, I don't know if Debbie, if you have an answer, are we able to separate it by the dependents and, you know, family, children versus spouses and have those different subsidies? I think we are, right?
Debbie Donaldson, for the record, I believe our data warehouse will give us that information that we need. And so we can see kind of specifically looking at, you know, average costs for the employee compared to average costs from spouses versus children. And then it's, you know, to what Chair Wells said, it's really a policy decision of where you want to allocate the total dollars and how you want to allocate the subsidies within each of the different tiers. We can definitely give you the information that's needed to help make decisions. But yes, and we can give, if it's suitable to PEB, we can provide some different scenarios and kind of give you different ideas as well.
Tom Zumtobel, what might a scenario look like? When you say that, what are you envisioning that it might look like?
I would envision that potentially you give more subsidies to the employees and less to the dependents. And what would that potentially look like? We would need to work with PEB as far as, you know, I haven't heard and I don't want to speak, you know, but right now that, to Chair Wells's point, the total state subsidy is the same across each plan. If you want to change how those are bucketed, potentially, you know, that's a bigger task for sure. But, you know, we could definitely take a look at that and see kind of how that would change things. That would, you know, I'll just share that how that's, if that's allocated different, it's going to change member behavior as well.
No, that's right. And Tom's up to again. So if you gave us that scenario you described, that you could say the kind of maybe the cost impact, would you also be able to tell us how you believe that would influence the migration between plans?
Debbie Donaldson, yes, we could share that information.
Laura Rich for the record, and I think the other part of this conversation is actives versus retirees, right? So there's that part of it too.
Debbie Donaldson for the record, that is correct. So there's more, you know, looking at it from a total enrollment perspective, you know, the enrollment is for retirees is more weighted towards the retiree only and retiree spouse. And so, you know, there needs to probably be conversations of, you know, do you want different tier ratios for actives versus retirees, or do you want it commingled at that time? That could impact the employee plus spouse tier ratio for sure. Lots of decisions. And Debbie Donaldson, again, we want to make sure too that we're not overwhelming you with lots of different choices because this can get to be a little bit of there's lots of different choices that you can make.
It could get overwhelming.
Yes.
Yeah, that's why I don't even know where to start with this.
Yes.
Keiko Duncan for the record, is there, I know we did something similar when we were looking at all the different rate settings and months ago, but is there like a standard or a general comparison to other employee plan models for other states? I recognizing that Nevada is special, all states are special in their own right.
All employers are special.
All employers are special, yeah. But with some visibility into that of what other state plans are doing, is that a place to start, or is that it's just too different by state?
So we've kind of seen that a little bit in some of those comparison slides that they presented in the, I forget what you call it.
I remember, but I'm not remembering like specific to like
We didn't
this
do
type of thing.
percentages, it just basically shows this is what the state pays versus what the average
That's
other
right.
employer pays.
That's right.
And so it was averages, it wasn't based on percentages, it was based on employee share of the premium versus counterparts, employer share, the employee share. What we could do, here's one way to model this, and this is probably the best way to model it. We already have 27 rates. So we could take that table for active employees and model. I don't want to do more than 3 scenarios. I think once you go beyond 3 scenarios, it's just too much. So you could do the existing, or to me, it's historical, 7 and 32. 7% for the employee, 25% for all dependents. You could and subsidize that the same across all 3 plans. You could do a second one that has a $0 employee subsidy for the CDHP, so $0 employee share on the CDHP, a slightly higher dependent share for the employee. And we'll have to actuaries need to kind of work this out so it's relatively cost neutral. So that the increase in the subsidy for the state's component will be offset by a decrease for those with dependents. Same plan, or same subsidy across all three plans. And then the third one, we could do, because those other plans are getting to be more expensive, you could do a state share for all three plans. So you set it, whether it was 7% for the active employee, 32% for dependents as the employee share, but it's 7% of the three distinct plans. So it's a different subsidy for all three plans. And like, we could do 4, and then the fourth one would be the one where we have a different subsidy for spouse versus children.
Kicking for the record, so would the purpose of having a different subsidy for each plan be essentially countering those potential behavior economics that we?
It's gonna create more.
Oh,
It's
okay.
gonna create lots more. It'll
Okay,
create a
it'll
lot more,
compound
it'll
it, right.
create a lot more movement, likely back into the middle plan, the LD PPO plan.
But what would, so maybe just generally outside of this, like what would the purpose be of having them subsidized differently by plan then, if it's just going to compound that problem?
So right now, when you're creating the subsidy, the problem is that the trend is much higher for the PPO and the EPO. So as those plans get more expensive and you're creating a subsidy based on the CDHP, which is not growing at the same rate, the employee shares of those other plans are continuing to grow differently than the CDHP premiums are.
So Laura Rich for the record, I mean, there's some other areas too that I'm looking at, like, you know, for example, retiree dependents, right?
We haven't got to retirees yet, so
Okay,
we're
okay.
just trying to figure out a
Okay.
reasonable number of employee scenarios to pick from. And what we don't really want to get into is like, is trying to pick the scenario based on what the outcome is. This
Right.
needs to be fairly objective to, you know, it becomes a math exercise. We don't want to, you know, we don't want to subsidize it at such a rate that everybody moves into a plan that costs the state a lot more money, because at the end of the day, then what that's going to generate is the premiums going up, and then the subsidy won't cover as much, and the state employee share will go up anyway. So at some point, you've got to be cognizant of that. But I think that if we did those 4 scenarios, we don't have to pick one of those 4, but I think those are the 4 to bring back, and then you pick one from those 4, or you pick one that is maybe slightly different than those 4. And then on the retiree side, the 70% to me was incredibly high, and it explains why I have much cheaper insurance than my active employee counterpart. Because I don't think it's been the 70% in the past. And looking at Dr. Urban's table, which I appreciate very much, by the way, because I knew we had set lower or retiree only shares in the past. I didn't remember the exact percentages, but I think that we need to set them more in line with historical averages. And I believe when we first did this, there was a differential between employee and retiree, but the same differential between retiree and dependent. So the employee share versus the retiree share was spread out, but the differential between primary and dependents was the same 25%. And so we could do that with historical numbers. The 64, I think, is what it said on there. And whatever that ends up being, 64 minus 25, 49. We could do it with primary only. So we only subsidize their primary retiree. We don't subsidize any spouse or dependents. And we could do a third one that subsidizes scenario. Maybe the third scenario is cutting the dependent subsidy, reducing the dependent subsidy for the retiree side. A bigger share being for the burden of the retiree. Maybe those are the three I can't, it's hard to think of. Anything else, any other ones that people can think of on either side, active or retiree? Is there other scenarios that we can start at as a baseline?
Chairman Wells, I think what you suggest is it gives us something to look at. You can't conquer them all, but at least if we have those scenarios, then we could figure out a way to think it through, because I need something like that to understand, so they sound good.
So does that sound like a reasonable step to bring back to September? I don't think that's super difficult because we already have the rates. It's really just percentages of premiums. I don't think it takes too long to create those tables. Any others? Going once.
Point of clarification, Chair Wells, would you like us to look at the ratios, the 1, 2.0 and those subsidies to make sure, okay, we'll bring that back and have that prepared for September as well.
Yeah, because I'd like to update the balance of that first table. Which means we need to do the analysis of children. Yeah, when we did this before, spouses were more expensive than
Yes.
primaries. I don't know that. An adult's an adult, I don't know, but it'd be nice to know. So it'd be nice to know what spouses are versus primaries and dependents, children as a bucket.
Anecdotally, theoretically, there, back then, if it was being enforced about dependents taking the health plan of the employer, theoretically, there was probably a little bit of adverse selection, which made the spouses be at a higher rate than the employees. So, yeah.
All right, so you're clear with 7 scenarios, 4 for active employees, 3 for dependent or for retirees, sorry. Everything's good? Okay, then we won't take any action on it today. Agency requests will be submitted as outlined in this document. And then if we want to update these for the governor's recommended budget to the legislature, we'll need to do this no later than the October 2nd meeting. All right, let's take a short break. Come back at 11:05. Minutes. All right, we'll call the meeting of the Public Employee Benefits Program Board back to order. Move on to agenda item number 8, the report concerning costs for retired state employees to obtain coverage through PEB under Medicare and not under Medicare for transmittal to the Interim Finance Committee pursuant to NRS 297.04347. Ms. Mooneyhan and Ms. Donaldson.
Thank you, Chair Wells. Brandy Mooneyhan, lead insurance counsel for the record. Just some background on what this report is. In Senate Bill 494 from 2025 legislative session that created the Nevada Health Authority, one of the provisions that the legislature included was this new provision, which is now codified at NRS 287.04347. And what it asked for was that every even numbered year by August 31st, that the PEB board compile a report concerning the cost, and I'll quote, for a retired state employee to obtain coverage through the program under Medicare that is actuarially comparable to the coverage provided through the program, but not under Medicare. So in other words, compare the cost for Medicare retirees and non-Medicare retirees, and then submit it to the Interim Finance Committee through the Director of the Legislative Council Bureau. So Siegel and VIA worked closely together, and they worked very hard on compiling all of the relevant information. They created the report for your consideration to be transmitted. And Ms. Donaldson can answer questions about the details of the report, since she is the one who compiled. If you have any questions for me about transmitting it, I'm happy to answer those as well.
Ms. Donaldson, you're up.
Hello again, Chair Wells, members of the PEB board. So yes, I wanted a special shout out and thank you to VIA Benefits for their great collaboration on doing this analysis. So within your board packet, you'll see the outcomes in the report we provided based upon the analysis. And in high level terms, the conclusion of our analysis indicates that the benefits that are provided to Medicare retirees via benefits does provide financially, and looking at actuarial values, taking into consideration subsidies, financially better benefits that can be offered to retirees within PEB offerings. That's the 3 plans, the consumer driven health care plan, the LDPPO, and the EPO HMO, again, considering subsidies available to the various different groups of retirees based upon the different buckets that are outlined in the plan documents. That's the high level conclusion, and I'm happy to entertain any questions.
Any questions for Ms. Donaldson? On the report. I have one. Can you address the rationale behind the exclusion of Part B?
Debbie Donaldson, if we're talking about the Part B premiums that the retirees pay, we did include the subsidy on the Nevada PEB side if they're eligible for the Part B premium. We assumed it, but it's really, we needed a comparison of apples to apples on both sides. So we excluded Part B premiums on both the comparison of looking at the benefits and premiums paid to members who are participating in the PEB plan, as well as via benefits. So we could have included both, but we had to be similar and treat that both plans similarly. And we just decided to exclude them and just really focus on kind of the HRA contributions for via benefits compared to the other subsidies offered by PEB. So either way, it wouldn't have mattered because it would be on both sides for the comparison.
Other questions? Seeing none, this is an action item to submit this to the Interim Finance Committee through the Director of the Legislative Council Bureau. You have a motion to approve and submit this report to city council, your staff for transition to our finance committee.
Laura Rich, so moved.
Second.
I have a motion and a second. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Close agenda item number 8, move to agenda item number 9, pharmacy benefit manager rebate changes. I have Ms. Donaldson. Oh, sorry.
They're both
I have
there.
Ms. Donahue and Ms. Daly. And
Just Daily. Amy Daly with Express Scripts for the record. Today, Teresa tasked me with providing some background information on rebates, how we're seeing rebates change in the industry. We are seeing some of the rebate figures for PEP go down, and I'm gonna explain why that is occurring. And then sort of the future of rebates and pricing options as you guys look to RFP pharmacy benefits in 2028. So a lot to cover. This is gonna be, I tried to keep it fairly high level because of the audience. And so certainly if you have questions, let me know. I would consider this like a 101, and then if we need a 201 or 301, I'm happy to do that as well. So rebates traditionally have been in place. PBMs have what's called a formulary. And we always do clinical first on formularies, and then there are financial considerations. So for example, we have a P&T committee of physicians, nurses, pharmacists that decide if we have to add drugs to our formulary. So there's nothing clinically equivalent on the formulary, or may add medication. So there's already other options on the formulary, or do not add. It's not safe and efficacious clinically, and we do not want our members to be taking that. So when the financial comes into play is when we have those may add. So when there's competition, there's other clinical drugs that are available. That is when our job as your PBM is to reach out to manufacturers and negotiate better pricing on your behalf. So to be on our formulary, you have to offer better financial position than other manufacturers do. So you're giving rebates behind the scenes, so it's not adjudicated on the claim, that are negotiated with pharmaceutical companies that are then paid to our clients. So that's basically why rebates exist. And so just some background on PEB's rebate arrangement with Express Scripts. So the way we negotiate on the commercial side rebates with our clients, there's 2 types of rebates that we talk about. There's the manufacturer share rebates or manufacturer payments that we get directly from the manufacturers based on your claims and the drugs that your members are taking. And those 100% of those payments are passed back to PEP. The way that the commercial industry has allowed clients and contracts to be built is that as the PBM, when we're doing RFPs and things like that, we guarantee a rebate by claim. So there's a second bucket of rebates called guaranteed rebates. So those are how states budget, because we've said for every brand claim that's dispensed, we guarantee $500, or but like that's just an example. We guarantee $500 for every brand claim that's dispensed for a PEB. Meanwhile, we're getting lots of different manufacturer payments behind the scenes, right? The second bucket, some of them may be higher than the guarantee, some of them may be lower. But what we're hoping is that when we guarantee that amount, it's going to basically come out somewhat equal, right? The guarantees are going to equal the manufacturer share. If they do not, we have to pay you more money. So the way PEB works is that you get paid based on the guarantees quarterly. And then at the close of the year, we reconcile to 100% of the manufacturer payments. So if 100% of the manufacturer payments were less than the guarantees, you already got paid what you were guaranteed. If the manufacturer payments were more than the guarantee, you get that additional money. You get 100% of the manufacturer payments. So those are important terms and things as we continue to have this conversation. Just want to make sure everyone kind of understands how that all works. Okay, so rebates have existed for a very long time and they've been relatively stable. In the last 3 years, we've seen some significant changes in the rebate pharmaceutical industry. It was all driven by government action. So if we go to the next slide, slide 2, this is a timeline from 2024 to current of what happened across the industry. This isn't just Nevada, this isn't just ESI, this is every PBM, commercial rebates, this is happening across the board. In 2024, the American Rescue Plan Act went into place. And what this resulted in is there were some really old drugs like insulin and some inhalers, where through this act, if manufacturers continue to offer the price that was in the marketplace on the commercial side, they were going to get dinged and penalized on the Medicaid side. Like they were going to have to pay more on the Medicaid side. So they changed the structure of how they were pricing these medications on commercial. So manufacturers control the price. They control what's called an average wholesale price, which is AWP, which is like your sticker price for drugs. And then all the discounts happen after the AWP, but the manufacturer controls that AWP. So as a result of the American Rescue Plan Act, these old NDCs, they reduced the AWP of their medication or the WAC, those are somewhat interchangeable, and made that lower. So they effectively absorbed the rebate into the actual price on the claim of the prescription and took the rebate away or reduced the rebate. So that was our first government action that resulted in manufacturers reducing rebates. The net result to PEB was neutral. So the manufacturers reduced the AWP by an amount that the rebate change was either less or neutral. Then in 2025, biosimilars became available. So again, this was another instance. Humira and Stelara were very highly rebated drugs. They're one of those two drugs were two of the drugs that would have been a lot higher than your guarantees and your contract, like the rebates we were getting from manufacturers. And when the biosimilars came to market, they decided that they had some high WAC options and some low WAC options. On those low WAC options, they did the same thing. So they reduced the amount of rebates available for the biosimilars and dropped the price of the drugs. Now in the biosimilar space, it was a significant drop in price because there was a lot more competition. Before, it was just Humira, which is an AbbVie drug. And after, now we have 6 or 7 biosimilars in the marketplace. So when you have that kind of competition, they have to compete in the marketplace. We only have 3 biosimilars on our formulary. So those biosimilars had to show up with the best pricing to get on our formulary. So there was a lot more competition, and there was significant savings for PEB on those 2 medications, which we'll talk about. In 2026, the Inflation Reduction Act went into place. This is the law where CMS is now negotiating drug prices for Medicare. So they took 10 drugs and they said, they negotiated with pharma, just like we do, and said, this is the most we're gonna pay on the Medicare side. This has to be the price for these 10 drugs. That leaked over to the commercial side. So these manufacturers, a lot of these drugs, there were 10 on the Medicare side. There's probably, I think, 7 where they also changed their pricing on the commercial side. And what that means is, again, they did the same thing. They dropped their AWP or WAC, and then they reduced the rebate behind the scenes. All of these changes, I would say, are good for PEB because you're getting the rebate or the discount on the drug on the claim. You're not having to wait for these rebate payments that come months after. However, it does mean that your rebate payments are going to decrease over time. This is not going to stop here. We have every year now, CMS is going to negotiate 10 more drugs for the Inflation Reduction Act. We have 4 big biosimilars, Enbrel, Ibrance, Cosentyx. Those are going to be coming out in the next 2 to 3 years. So this is going to keep happening. I think every year now we're going to see NDCs on 1/1 where this pricing dynamic changes. Any questions on that piece? Okay, so we wanted to specifically address what we're seeing in PEBS rebates, which is slide 3. Okay, so this was, these are your payment figures. If we look at the brand claims, you can see that you're relatively steady in terms of the number of brands that are being dispensed. That means, you know, your guarantee payments, like we're not seeing a large fluctuation in the number of claims. So that's one thing you can take out. The next column's minimum guarantees. So those, we talked about those, right? Those are the guaranteed amounts times the brand claims. So when these manufacturers started to mid-contract, right, for PEB, and a lot of our clients were in mid-contract, when they started changing inherently how they price these medications, we came out with methodology, which we vetted with consultants and clients and had signed off on, to ensure that, hey, these were all rebates we were capturing for these drugs. They're no longer available. They've moved into the price of the claim. So now we need to make sure we're not being held responsible for the same level of guarantee because the bucket of rebates is much less. So we came up with rebate credit methodology, and those credits amounts, which are increasing, as you can see in the adjustment column, those are, you know, steadily changing over time based on that timeline I showed you. More NDCs are coming in, some NDCs are leaving. And so the total payment column is what PEB is getting paid quarterly for rebates. So that's the guarantees minus the rebate credits. Those are the actual payments. And we saw a reduction of about 6.5% in those for when we're comparing fiscal year 25 to fiscal year 26. So wanted to explain more about that 7% drop because it's getting a lot of questions from PEB and we wanted to dig into it further. So I said that Stelara was highly rebated, and these are just directional numbers. Again, I'm trying to simplify for the audience. But in 2025, for example, Stelara 90 milligrams, the AWP was about $34,000, right? And the rebate was $15,000, big rebate. When the biosimilars came in, they dropped the AWP to $5,000, but the rebate dropped to 0 to $1,500. So you can see your rebates are going to go down, but on something like Stelara, PEB is saving money, right, overall. So you don't want to chase the $15,000 rebate. You want to get the lowest net cost, which is after the AWP minus the discount, minus the rebate, you want the lowest cost. So 15,000 big rebate would have made your rebate numbers look better. But we don't want to chase a big rebate number. We want to chase the lowest cost for a PEP. So when we look at all your rebate payments in that total payment column, so all the quarterly guarantee column, if we total that up for fiscal year 25 and fiscal year 26, you see you have about a $2.4 million difference between those two rebate numbers. That's got those AMP cap dollars, that's got IRA dollars, that's got biosimilars. But if we just isolate biosimilars, which is the biggest difference, the biggest reason your rebates payments are going down. And if you think about it, when that rebate goes from 15,000 to 1,500, your guarantees are going to go down because we're taking the credits, but your manufacturer payments are going to go down too. So like they're not paying you in the rebate, remember it's in the price. So when we look at that net change for biosimilars though, when we take the Humira claim compared to the biosimilar claim, which we can show claim by claim, I don't have that here, but we can go through that. The total savings for the biosimilars was 2.7 million. So you can already see you're better than neutral. So your rebates, yes, we can say they're going down. But if you look at the ingredient cost reduction tied to the biosimilars, it outweighs the rebate loss. So that's the important thing you have to focus on. And that's just biosimilars. You know, there's AMP cap and the IRA drugs in there too. So, you know, PEB came out ahead, but if we only look at rebates, they are going to go down. So that's the overall message. The next slide, one of the things ESI has been working towards, and you guys have been working with us on this, is moving to more transparent, but also simplified pricing options for clients. So we don't have to continue to haggle about rebates and make sure we're protected and you're protected. So Nevada, in the last RFP, you asked us to do acquisition costs, which is what we pay to buy drugs for a mail order and specialty. That is in place for PEP today. You have 100% pass-through at retail, which is what we pay the pharmacies is what we charge PEP. You get 100% of manufacturer payments, that you get all the rebates that we get on your claims. And so you have already taken steps to move to a more transparent, non-rebate, driven model. However, there is still more we can do. And we are building, and this is an option, not something that's required of our clients, a rebate-free model that will be available in 2028. So what does that mean? So as I've shown you, the rebate landscape is changing and rebates are going down. That doesn't mean costs are going up, right? So what we need to do is shift from a rebate guarantee focused pricing model to let's just guarantee the lowest net cost. So if we guarantee a per member per month dollar amount for PEB, that, we are motivated to get that as low as possible, right? So if we meet that, we'll have penalties if we allow your costs to go above that. So the conversation's less about how much rebates are we getting you? It's about, did we save you money across the board through everything, every financial component? So it's a lot more simplistic. We won't have to continue to talk about these new NDCs that drop price, because as long as the price is low, it doesn't matter where you get it, right? From the rebate, in the price of the drug, on the claim, retroactively. The other thing that PBMs have been getting a lot of pressure for in the marketplace is, you know, you have all these rebates, but members aren't benefiting. So one of the things we're gonna do with this new model is pass, if clients want this, pass rebates back at the point of sale to members. So when you have high deductible plans, those rebates can go directly to the members to reduce their deductible out of pocket, et cetera. That is an option. You can also continue to receive rebate payments. We're building acquisition cost into the retail pharmacy setting, so that's really new and innovative. You know, I think that hasn't been done in the past, and that's really to help retail pharmacies who are saying they're not getting paid enough. So like they're getting some negative margin drugs and some positive margin drugs, but if we pay them based on what they're buying at, plus a admin fee, that's gonna help resolve that situation. And then we are also, you know, this is going to, the only way through this model that the PBM would make money, and this is similar to your deal today, is through an admin fee. So it's taking out, you know, the worry of margin in different places. I can spend a lot more time on this. I think this is a good model for PEB to consider for 2028. You'd have to structure RFP like this. I will say, it is happening in the marketplace. You know, someone like CalPERS has a PMPM. That's what their whole contract's based on. But it is relatively new. And so we're not seeing a lot of RFPs that allow us to bid with this type of a model today. And that's because people are worried about budgeting and how are they going to, you know, it's a switch in underwriting and there's a lot of different levers. So this has not, while it will be available, you know, it's innovative. So it's relatively new. I think we have one client that's going to do it in 2027 that we already know of. But it hasn't reached a tipping point. I think this is absolutely where the entire industry is heading because of all the regulation, all the focus. We're all going to have to move to this type of a model eventually.
Okay, so Kay for the record. What about formulary changes? Because I know one of the other pieces in Express Scripts FTC, some of it had to do with like low WAC drugs. Sorry, my eye keeps twitching. Is that a part of you know, some of the new models that ESI is suggesting is making some formulary changes to that effect, or no?
Moving to, I think you mean, and I'm gonna restate the question, making sure we're using low WAC when available?
Yeah.
Yeah, at one point we were building a formulary that was going to, you know, be our standard formulary, but with low WAC. Now it is a part of our formulary. So like if there's a low WAC, option, it's already, those are typically like in the biosimilar space, those are our preferred pricing options. So that you can get the rebate on the claim versus, you know, a payment that's better for you.
I think I got a question.
Yeah.
I know you stated that retail pharmacies were complaining about the cost and things like that, and you guys were going to give them an admin fee. Does that admin fee fall back on PEB, or is that coming out of ESI?
So if we're going to pull through the acquisition cost of what they buy the drug at, and that's going to be a big recon process, I can definitely go into that more. I will say again today, pharmacies are making money on some drugs and losing money on some drugs. So we're kind of pulling that into the middle where they won't make money. You know, we're saying you buy it, we'll pay you for that. But then they do need to make up cost of like dispensing and things like that. So they get a dispensing fee today. Again, you know, the way that would be structured is we'd guarantee a PMPM. So you'd have to be comfortable that that cost we're guaranteeing is gonna save you money. So like, say you have, I'm making this up, but you have a PMPM of 90 today. We bid that business, we're gonna say, you know what, we're gonna guarantee 85. Your PMPM is gonna be 85. So you know you're gonna save $5 over that contract year. And it's gonna have to be more annually refreshed, right? Like every year, we're gonna have to refresh the PMPM. But you know you're gonna save $5 on every single one of those members. So that's what you know for your books. Meanwhile, we do our business behind the scenes and we have to find a way to save $5 or we're gonna pay you penalties. So it becomes less important, you know, what's on the claim. What we're guaranteeing is that PMPM cost. Hopefully that makes sense. So we're trying to take out your concern about all those types of levers while making our supply chain, you know, comfortable that they're gonna make or, you know, make some money, make a margin.
Any other questions? Ms. Donaldson.
Thank you, Chair Wells. I just want to make a couple comments of what's happening kind of from a macro level, what we're seeing across the industry nationwide, maybe a couple cocktail comment points for y'all. But also talk about kind of things to maybe potentially, you know, we're taking in consideration when we built your biennium budget, also things to potentially consider for a 2028 RFP. So a couple of things that we're seeing. The industry is changing and it's changing quickly across the country on how PBMs function today. Traditionally, like your plan is set up, it was a discount. It was discount off AWP or WAC with minimum rebate guarantees. Industry is moving away from that and it's progressing away from that. I would say that the new thing is PMPM guarantees that folks are moving away to say, we're guaranteeing, we don't care what the discount is, what the minimum guarantees are with rebates. We want a PMPM per member per month is what I mean by PM guarantees. How I would also say there's been a lot of things happening on the federal level that you may have seen in the news as well. Just so you guys know, the implications, there's the Consolidated Appropriations Act that came into effect that affect how PBMs function. There's what Amy noted, which was the FTC, the Federal Trade Commissions. They have made, there've been rulings and then you guys have done settlements. So the big three pharmacies are in the if they haven't already, the two of the three, at least I am aware of, have made settlements.
Including us.
ESI and CVS Caremark, and CVS Caremark made their settlement about a month ago. How they're approaching that is slightly different, and how these are applying, how PBMs are applying some of these changes that are coming up in 27, but most notably in 28 is different by PBM that we're seeing across the country. These changes on the federal level are required for plans that are subject to ERISA. So a lot of the things that Amy noted that they're going to, like the low WAC and kind of the more transparency and rebates, those are requirements for ERISA plans. PEB plan is not subject to ERISA. So the question is, you still have a choice. The question is, and it's varied, we think at this point, it's still rolling out, but it seems to be, is it gonna not be a choice of PEB? Is this happening across the book of business to say this is where we're going? Or is it a choice? And I think it varies by PBM. So that's important for you guys to know as you write the RFP for a PBM. The other thing that I'll just share is that kind of what we've looked at and when she talked about was everything that's happening with the biosimilars, because your current contract's in place that has a minimum guarantee. And when you pull out the rebates, there's what's called rebate credits. We want to make sure that, yes, there's savings going to a low WAC, but we want to make sure that there's a differential, the 1-to-1, you're net neutral. So the savings you're getting from the discount and ingredient cost is net neutral from like what we're getting in rebate credits. So before this was the low WAC drug was implemented compared to afterwards, we want to make sure that you're at least net neutral on that with the rebate change. More to come on that. We've been working with PEB, we've been working with ESI to get more detailed reporting so that we can get comfortable, and we're getting close, I think, but that we're getting comfortable with that differential. That's something in the commercial plans that on the Medicaid side is more prescriptive. And so that is a difference that we're working out and trying to get comfortable with. As we thought about doing the biennium budget, Siegel erred slightly on the conservative side to say that they're telling us it's 1-to-1, but we're not sure it's going to be 1-to-1. So we built in a little bit conservatism when we projected those rates just to be careful until we get better comfortable with kind of how things are flowing through the plan. I will say, and I'll just end on a good positive note, that we just got a report this week from ESI related to kind of minimum guarantees. And, based upon new contract terms, that is showing positive indications that, that was a good negotiated plan. We set the rebate guarantees. PEP's getting about $2 million back in addition to meet the minimum guarantees. So that's a good thing. So more to come as the industry starts to morph and change. And quite honestly, the PBMs are still trying to figure out what they're going to offer in 2028. So a lot of change happening within the industry within the next 2 years.
Questions?
Question. Tom jumped about. I'm not sure which one of you would respond, but I was thinking about the settlement and we just extended our agreement. Is there any way that we could, because the settlement actually forces the transparency for ERISA plans, right? And is there a way that, and we had access to that agreement. I think it's a standard offering now, isn't it? Don't you have an obligation to offer it as a standard offering?
2028, I believe is.
Yeah, so the last slide I showed you, like the rebate free piece and some of the things we're building into that new pricing model, those were the agreements associated with the FTC.
Yeah.
And so I can give you a rundown of exactly what we agreed to and how we're incorporating that. But Debbie's right in that some of those achievable milestones aren't effective today. It's part of this new option, which will be an option for clients. We will not be forcing clients to take it.
What's the timeline on the settlement that you're obligated to start offering?
So there were different pieces for different timing, and I can definitely resend that to you. But like the rebate free piece isn't available until 2028. And that's really what I think the federal government was excited about, is making sure that if you want them to, that members can get access to rebates as well. Because, primarily clients have been keeping those and then using them to reduce premiums. But the federal government really wanted to make sure that those rebates end up reducing copays.
And there was several transparency provisions though, beyond rebates.
There's a lot of different, so the Consolidated Appropriations Act is where like a lot of the transparency reporting was required. We did agree, I think, as part of the settlement on a few additional transparencies in terms of like what we're gonna share with members in terms of rebates and things like that as well. So yeah, there's it's hard to use the word transparency because it means so many different things, but and I think we throw it around in lots of different ways, but we are going to be required to provide more communication to members as well.
Debbie Downson for the record. I'll just add the Department of Labor has also issued proposed rules about transparency as well and reporting. But to Amy's point, the Consolidation Appropriations Act has some transparency rules that I think would go effective. I think it's August 3rd, 2028, where those have to be effective. But again, those are for ERISA plans, to your point. Yeah.
And a lot of that is just submitting data to the government. So, is that it's not necessarily transparent for you guys, right? It's, we're giving more information to the federal government. So is that transparent?
Debbie Donaldson again, the FTC, I think, is it 2029, your requirement for more transparent reporting in
Right,
general? I
right.
think it's 2029 with the FTC portion of it.
And I need to send the slides and I will send a breakout of exactly all the timing associated with everything we agreed to in the FTC settlement.
Any other questions? Seeing none, this is information and discussion only. Move to item 9, move to agenda item number 10. Nevada Health Authority statewide purchasing delegation discussion.
Teresa Carson for the record. This item is to recommend to the board to take action to delegate purchasing strategies for the pharmacy benefit manager contract, our dental benefits network administration contract, and our actuarial services contract to the Nevada Health Authority. Those are the 3 contracts that we're currently working with to coordinate procurement with them currently. So we need to make that official with board approval. I think the intention of the Nevada Health Authority was to align a lot of our contracts under the health authority to help with a sustainable purchasing strategy. So these likely won't be the only contracts that I bring to you asking for such delegation, but these are the ones that we have current working groups with the health authority on currently.
Questions?
I have a Tom Zumptable for the record. I'm just curious. It's a Nevada Health Authority statewide purchasing delegation. Is that just a label for this item or is that a thing?
So it's the intention, I believe, for these 3 contracts so intention is important, right? It is the intention to release contracts with multiple scope of works for different lines of business under the health authority. For instance, with the pharmacy benefit manager would have a scope of work for Medicaid, a scope of work for PEB, et cetera, et cetera. Now, as we're building that and meeting with vendors, it's entirely possible that any one of these, specifically, I'll use the example, the dental benefits network, right? The services that the health authority is trying to procure for Medicaid would be different services than what we are trying to procure with PEB. That doesn't mean that they can't be aligned or outlined separately under a different scope of work under one RFP. So does that clarify?
No, but that's good. I was just mostly curious because it's statewide and it's all state. I didn't know if there was other indications of this, but really you're just delegating our services to get their purchasing power is correct. Okay, correct.
So as part of the creation of the health authority, I mean, that was the idea, right? We're gonna try to use the leverage our purchasing power. This is gonna require a rewrite of a section of our duties, policies, and procedures under the contracts, and the bill outlines some provisions about the health authority can do certain things that currently can only be done by state purchasing. So there's part of this law that delegates contractual authority from the state purchasing to the health authority for these contracts. But right now, our duties, policies, and procedures say the board still has that responsibility. So with this, we are delegating the board's responsibility for these 3 to the health authority as part of this bigger recruitment or bigger arc.
And potentially gaining some efficiency.
Okay. So yes, there will be more, and there will be a rewrite of the contract section of the duties, policies, and procedures that need to go along with this. Any other questions?
Yeah, just to clarify why I was acting the way I went, we're really delegating to the Nevada Health Authority. I read it as like it was creating a delegation, and I apologize for that, but that was the clarification that I was looking for.
Yeah, this is delegating the board's authority for these three procurements to the health authority. So we won't be responsible for setting the review panels, hearing the presentations. That'll all be done. This is an action item. Need a motion to approve the delegation of those three RFPs to the health authority.
I'll move to approve.
Motion, give a second. Second by Mr. Member Baton. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Close agenda item number 10, move to agenda item number 11, contract status report.
Thank you, Chair Wells. Brandy Mooneyham, lead insurance counsel for the record. This report kind of follows on the item that you just considered. Normally this item has the current status, has a chart of the current status of contracts. Once the report takes into account those delegations that you just approved, some extensions that we're seeking board's approval of. One of those is with the PPO. That will give the health authority time to figure out what they're going to do with that. I mean, how they're gonna go out for that plan to procure those services for PEB and other state entities. Same with also seeking an extension for the health plan auditor and the HSA HRA account manager for the same reason, just to give the individuals flexibility to pursue those strategies that they have to kind of try to leverage their members with our members. Also, this chart also reflects unbundling services, which was discussed at the strategy session. So in other words, right now UMR provides medical and dental claims administration, BPO network services, and case management services to PEB. So this chart reflects perhaps those may be broken out into different contracts going forward. So this is just to reflect kind of the way things may be headed. There's the current expiration date and perhaps anticipated expiration date, assuming that you approve all of those extensions. In addition, one of the contracts that's expiring at the end of this year is with Eide Bailly, who does financial audits of PEB. PEB has negotiated with Eide Bailly a 4-year extension. Currently, Eide Bailly does high quality work for PEB. It also works on this statewide audit. So they have a lot of experience working with the state procedures and understand state procedures. They're working with our accounting team, our CFO, to modernize and improve PEB's fiscal processes so that those audits can get better and better. And the cost is less than 3% increase per year. So in addition, the one other contract that's expiring at the end of the year, PEB and NVHA staff are meeting with the vendor weekly and getting closer all the time to finalizing that contract. Just so you know, the other one that's set to expire really soon should be, you should be seeing a new contract on that, we hope, in the next few months before the end of the year. So with that, I'll take any questions, and also we're asking that you approve the extensions and the amendment of the Eide Bailly contract.
Any questions? Hearing none, we need a motion to approve the extension for PEB's diversified dental contract with Diversified Dental until June 30th, 2028. The contract with Brown and Brown / Claim Technologies till June 30th, 2028, and the contract with HSA Bank for HSA HRA account management services until June 30th, 2032. And then approve the amendment to the existing contract with Eide Bailly until December 31st, 2030. I've got a motion from Member Duncan, second from Member Baton. The motion and a second on those 4 items. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Close agenda item number 11, move to agenda item number 12. The Q2 and Q3 Claims Technologies Incorporated audit findings for the State of Nevada Public Employees Benefits Program administered by UMR. Ms. Amato.
Afternoon. For the record, I'm Joni, Joni, Amato, Amato. Today, I'll be discussing the both quarter 2 and quarter 3 2026 UMR audit results. For quarter 2, that included medical and dental claims processed during the period of October 1, 2025 through December 31, 2025. And for quarter 3, that included all claims processed during January 1, 2026 through March 31, 2026. The audit components for both of these quarterly audits included quarterly performance guarantee validations, 100% electronic screening with 50 targeted samples, and a statistically valid stratified random sample of 200 claims. And I'm going to walk through the second quarter results, and then I'll move on to the third quarter results. The medical and dental claims paid during the second quarter totaled approximately $71.5 million and included approximately 270,000 claims. UMR's performance in the financial accuracy and overall accuracy decreased in the second quarter when compared to the prior quarter's results. Claim turnaround time improved for claims processed within 14 and 30 days. The performance guarantee for claim turnaround time was 92% within 14. Claim turnaround time of 92% within 14 days was met. However, the performance guarantees were not met for financial accuracy, overall accuracy, and claim turnaround time of 99% within 30 days. This results in a penalty of 3.5% of the administrative fees for the quarter, or $50,569.38. CTI also reviewed UMR's quarterly self-reported performance guarantee results and noted that all 27 of those were met. The random sample audit identified 5 errors, 3 of which were overpayments and 2 underpayments. The errors were cited in the categories of provider discount calculation, deductible, coinsurance, and copayment application, and a denial of an eligible expense. Through CTI's targeted testing, we identified improvement opportunities in the areas of duplicate payments, plan limitations, payment in excess of billed charges, copayment application, and preventive services paid with patient cost share applied. So those are the second quarter, so I'll move on to the third quarter. And for the third quarter, claims paid totaled approximately $77.6 million and included approximately 250,000 claims. UMR's performance and financial accuracy and overall accuracy decreased in the third quarter when compared to the second quarter. Claim turnaround time improved again for claims processed within 14 days and 30 days. The performance guarantees for claim turnaround time of 92% within 14 days and 99% within 30 days were both met. However, performance guarantees were not met for financial accuracy and overall accuracy. This results in a 2.5% of the administrative fee penalty, or $36,988.57. Again, UMR met all of the 27 self-reported performance guarantees for quarter 3. The random sample audit identified 6 errors, 4 of which were overpayments, 1 underpayment, and then 1 under application of the deductible. Errors were cited in the categories of provider discount application and incorrect coinsurance application. And for quarter 3, CTI's targeted testing, we identified improvement opportunities in the areas of duplicate payments, plan limitations,
incorrect provider discount, payments in excess of billed charges, the co-payment application, non-compliance with pre-certification requirements, and unbundling. CTI recommends reviewing the errors that were identified in both the random and targeted samples to ensure that root causes are being identified and that any claim process or training or system corrections that need to take place are happening where they're appropriate. Thank you, and I'm happy to take any questions.
Thank you, Ms. Motto. Any questions?
Kate Duncan for the record. I've got the same question and comment that I've had for the last, I don't know how many. But this in front of us has reflected 2 consecutive quarters where the financial accuracy and overall accuracy were not met. What's been done about that? Has a cap been completed by UMR? How are we preventing a 3rd quarter consecutive of?
This is Jennifer Spencer from UMR. I did want to mention that, you know, we do take all of the information from CTI. We have implemented additional reporting and just looking at anywhere possible. We're looking at our analysts, making sure all the training is there. If we have issues, of course, identifying those. We have, as I said, additional reporting that we've put in place to monitor specifically any of these types of errors that are coming back on top of everything else that we're monitoring and looking at. So it is a continuous process to make sure that we are reviewing all of these claims and making sure that we are, the goal is to meet this. Absolutely.
Kate Duncan for the record. I appreciate that, but I'm remembering you saying the same thing at the last 2 meetings that I asked that. So what has been done or what will be done differently? Because obviously those efforts have not worked.
We have put in additional reporting processes, and we have additional staff that we have implemented to monitor and audit on top of what our internal quality audits are. So we have implemented additional auditing processes.
Okay, have those additional reports been reviewed by the PEB staff, or what, you know, what are those reports that are now different?
Oh, I can get those to find out for you and send those over. I know that we continually work with the PEB staff, and I believe we have UMR staff there as well. So we can identify all those additional reports and provide that to the board.
Okay, I mean, I think I'm a little bit less concerned about like myself and my fellow board members reviewing said reports and more concerned about, you know, do we have a specific action in place and a recorded result at the end of the quarter as to whether or not said action has led to improvements and or if additional pivots need to be made. I mean, that's pretty standard corrective action plan work.
Yes.
And I think the corrective action plan, I think that should be, you know, submitted at least for the board to review and see was completed. So we can kind of make actionable decisions that should be, you know, hopefully affecting future quarters to meet this. I think, you know, not to speak for Monica, but I think for financial accuracy, if we're just continuously not meeting that accuracy, doesn't matter that's a 1.5% off, right? You know, we've only done an audit on 200 random claims of the, you know, many thousands and thousands of claims that we have, right? So I'm concerned that, you know, this is going to affect our budget planning if we are not going to be accurate in our financial reviews.
Yes, understood. And we can provide that action plan for the board.
Okay, I would like to see that at least. I don't know about you all, but yeah.
Yes, understood.
Any other questions? Yeah, so I'll say, you know, a lot of these appear to be manual overrides of problems. So yeah, corrective action plan on what's being done to address these manual override issues. But I will tell you, there's some concerning ones on here for me this time that are systemic driven, you know, including one where the charges were paid or the amount that was paid was greater than the amount that was charged. I mean, that's a pretty easy system edit that seems to have colossally failed. And so, how did that fail, and what's being done to make sure that something like that is corrected? Because that just is, to me, that's a basic one.
Which is a good point, Keiko Duncan, for the record, because for some of those systemic ones, the resolution from UMR's perspective should not be just to resolve that particular claim that was called out in the audit, but you guys need to be auditing then that entire system edit for all claims that might have hit that.
Yeah.
Because my concern is, yes, we found it one time, but do we have 1,000 of them that all hit the same system edit and caused a problem? So how do we make sure that that's occurring?
Yeah.
Or I don't know, UMR, maybe yes or no question, have you guys then audited the full system and found additional claims that were affected in the same manner?
So this is
Jennifer.
Norma Braun from UMR. Can I jump in here and just ask a question
Sure.
of CPI? Because we do have some situations where a DRG is paid and the billed amount can be less than DRG and it's still paid correctly. Have we made sure that we've excluded all those situations?
So, Helmut, this is Jennifer Spencer. And yes, when we review this information and we provide it back to CTI, we do identify if it's a DRG case rate or a contract rate.
Right. So
we
I
do
guess the
identify.
question is to CTI though, are they looking at those exclusions, or are those ones that, just because the billed amount is less than the paid amount, they're automatically throwing it on their report?
Well, the UMR responses on this is that they agreed with the findings. So apparently the finding was a legitimate one. So the UMR had an opportunity to say they disagreed with it for that reason, and they did not.
Okay. I just wanted clarification from CTI that was the case then. That's fine. Thank you. We'll go back and talk to CTI about it some more.
Yes. And this is Jennifer Spencer again from UMR. I wanted to answer the board's question regarding impact reports. Yes, we do run impact reports frequently. It's not just specific to this one claim or this maybe one provider or one code. We are running impact reports across the board to monitor, to make sure, do we have a larger issue or not? Is it again, an analyst? Was it a manual error? Is it a system error? So we are taking all of that into account, and we are doing impact reports consistently.
So, Keiko Duncan for the record, sorry. So if that impact report was then run for, say, this inherent system error, can you tell us what the fiscal effect was for all claims that hit that system error?
For this particular one, I can get back to you on that. I'm sorry, I don't have that available right this minute, but I will get that for you.
Yeah, I think going forward, I think that the board is really looking for is, what was the corrective action plan to fix that problem?
Yes.
Does that problem affect other claims? And if so, have those other claims been identified and corrected? And we're just getting agree or disagree on the claim that was identified by CTI, not what is being done to fix systemic issues. And I think that's really what we're looking for is what caused the issue, what's been done to correct it, and does it affect other claims that were not identified as part of the 200 random samples out of 250,000 claims? I think that's what we're looking for.
Teresa Carson for the record. I will say in some of the meetings that UMR and CTI have held with PEB, there has been requested follow-up of that nature that for specific findings, not maybe all of them, where we have asked for that detail and movement on that. Looking at Rhonda, like I feel like we just had this conversation about some payments over at UMC, right? Like, so I think maybe that's part of the piece that's missing on the report out to the board is the required follow through and action on UMR side to rectify some of those issues.
And Jennifer Spencer from UMR, yes, Tracy, you're correct. I know that we're, again, continue to work with PEB and provide this information. But as I'm understanding it, we want this documentation in the CTI report as well.
Yeah, I think
the impact.
Teresa Carson for the record. I think that the board needs to see the whole picture, right? And I think
Yes.
the report shows the findings and then UMR's response to the findings. It does not show the after conversation that's held with PEB that requires further action. I'll call it closeout, right? Because I made you guys work that UMC issue to death, I think, right? But like, I think that part, the final outcome needs to be included in the total of the report. So maybe Joni, we need to follow up on that piece as well, right? And just submit one final report. And I think that the board is identifying that this is a missing piece.
Okay, I'm happy to have that conversation.
Thank you.
And this is Jennifer Spencer, UMR, and yes, we will work with PEB and CTI as well for the best way to identify that on the reporting and provide that back to CTI for the quarterly reports back to the board and to PEB.
Thank you very much. Any additional questions? Okay, this is an action item to accept the quarterly quarter 2 and quarter 3 claims technology incorporated audit findings and assess the calculated penalties of $51,569.38 for Q2 and $36,988.57 for Q3. Have a motion.
Jim Barnes, I move approval.
Motion, do I have a second?
Rachel, second.
Motion and a second. All those in favor say aye.
Aye.
Any opposed, nay?
Nay.
Motion carried. Did you say nay, Mr.
I
Davis?
said nay. Yeah, I said nay.
So we have one nay. Motion carries. Close agenda item number 12, move to agenda item number 13, Willis Towers Watson's individual marketplace enrollment and performance report. Mr. Garcia.
Yes, hello, can you hear me?
Can.
Great, thank you. This is Chris Garcia with Willis Towers Watson. I'm happy to share with the board today our Q3 quarterly report. I'm going to try to share my screen. I just want to make sure you guys can see it.
We can see it, Chris.
Yeah.
And do you see just the presentation? No notes or anything additional?
See, yeah, we see it now.
Okay. And you see the executive summary page I just changed to. I just want to make sure there's no problems.
Yep.
Okay, great. Again, thank you. I do want to take a moment to first walk through the executive summary of the report. We do provide this every quarter. And then I can focus on certain areas if there are questions from the board, but I would also like to go to towards the end of the report. There's a couple of slides that we have that are related to different projects and different communications and things that we have going on during the quarter or upcoming items. So looking at the executive summary for fiscal year Q3, when we look at plan enrollment information, we had over 19,000 applications that have been processed for PEB retirees through VIA benefits. To give you an idea of like the breadth of and the scope of how many different applications we're processing over the plan, as well as how many different plans are being selected and how many different carriers we have. There are 978 plans that were selected between those different applications, between 105 different carriers that we have on our platform. Medicare supplement plans, they made up 82% of our enrollments. They're led by AARP at over 5,500 plan applications or enrollments, excuse me. Anthem Blue Cross Blue Shield was over 1,400 enrollments. And the average Medicare supplement plan premium is $149 per month. Conversely, the Medicare Advantage plans, those enrollments are about 18% of the overall enrollments when we look at PEB participants enrolling in a Medicare medical plan through VIA benefits. Those top providers, Humana is number one with 444 different enrollments. Hometown Health is number two with 426 different enrollments. The average premium for the Medicare Advantage plan is $6 per month. So certainly a difference between the average premiums for supplement plans versus those Medicare Advantage plans. We do a customer satisfaction survey that's available to participants when they have interaction with our customer service team. We really try to do that almost on every interaction. Outside of, say, somebody calling us multiple times in the same day, they're likely going to get one survey versus somebody who calls us in week one and then 2 weeks later they call us again, they'll get multiple surveys. We do capture, if they respond to those surveys, we do capture their satisfaction scores. So we break that down into two different categories. One is enrollment calls, and the other is our overall customer service calls. And then we kind of combine those scores to get an overall customer satisfaction result for that quarter. So for the enrollment calls, we had 28 surveys that were responded to with our interactions with enrollment calls during that quarter, with a score of 4.8 out of a 5. A 5 would be the top score that you can get. A 1 would be that the person was dissatisfied. So getting a score of a 4.8 out of 5 out of those enrollment calls is very high, and something that we really take pride in when it comes to providing that service for those people that are transitioning to Medicare and looking to enroll in a new plan. For those, what we consider a service call, which would be anything other than an enrollment call, we had 330 surveys responded to, and those customer satisfaction scores averaged a 4.2 out of 5. So think of these as somebody who maybe is having an issue with an HRA claim. Maybe there's a denied claim and they don't know why it was denied, and they call in and get assistance on why that claim was denied. And then they would receive that survey and they would be able to respond accordingly. When we look at the combined satisfaction scores, it's a 4.2 out of 5 between those two different categories. The other item that we like to include in the executive summary is the information about the HRA, or the Health Reimbursement Arrangement account. So at the end of Q3, we had 12,306 HRA accounts that were active. During Q3, we processed over 118,000 claims. So it gives you an idea, just for one quarter of the year, the first quarter of our calendar year, we processed over 118,000 claims. The good news is that we automate a lot of those claims as much as we can. That eases burden on the participant from having to submit manual claims. It allows our claims processing team to really focus on claims that require manual review versus automation. So 88.6% of those claims are auto reimbursed. They're reviewed. They usually, a common thing that we will see is we'll get a claim that comes through our different carriers that we work with. We get files from them where we receive the claim information for what the premium that the person has paid for their coverage, and we load that premium as a claim against their HRA, and we reimburse them accordingly. So we really try to automate that as much as possible, again, for ease of use for the participants, as well as for allowing our claims processors to focus on those manual claim submissions that we do receive, say through a mailed-in claim form or an online submission for a claim, something that might be out of pocket. When it comes to the total number of reimbursements, we paid out $8.5 million worth of claims in Q3. That ended up being 43,650 actual payments that were issued, the averaging of $195.66 per payment. So you can see we have a lot of volume coming in, a lot of claims being processed, and a lot of payments being released to participants to receive reimbursement for their eligible HRA expenses. So as I mentioned, I was going to skip to the bottom section of the presentation just to highlight a couple of different pieces of information related to some different operational aspects of what VIA Benefits does for PEB and your retirees. So one thing that we were doing in May, so this was reported in Q3, so this would have occurred in May, at the end of May. We do an HRA cap. So the purpose of this was to advise the board that we were planning on doing the HRA cap of $8,000 at the end of May of 2026. The $8,000 cap was an amount that was previously determined by the PEB board as the maximum that someone can have at the end of each May in their HRA. So on May 29th, we ran reporting on our system, identified people that had more than $8,000 balance in their HRA account, and we processed adjustments to decrease their HRA balance to that $8,000 cap. And then starting in June, if they received a new allocation for their monthly amount, they could go back over that $8,000 amount, but we did do adjustments to decrease anybody that had more than $8,000 at the time to the $8,000 cap. Leading up to that project, we were working with PEB, providing preliminary reporting, which PEB used to send out communications to 696 participants with available balances of $7,000 or more. That was done in, I think it was around March that those communications were sent, and that allowed those participants hopefully to take action, submit claims, and utilize their balance. So it was reduced their available balance to be below the $8,000 amount, so that they would not be impacted by the cap. So in our next quarter's report, so when we do the Q4 report, we'll have some more information about the finalization of that project and how many adjustments were made. I believe it was over $700,000 of allocation adjustments that were loaded to decrease people's balances below the $8,000 cap. The next slide that I wanted to show you talks about some spring retiree meetings that we held. There were 4 virtual retiree meetings that were hosted on April 15th and April 16th. And there was a live attendance option at the PEB office in Carson City. These meetings, they're designed to educate pre-65 retirees who are aging into Medicare, as well as educate active employees who are 65 or older, who are still working, but they're maybe considering retiring and transitioning now to Medicare, as well as educating Medicare eligible retirees who are already enrolled through VIA benefits. And we can give them information about, say, open enrollment season, as well as information about overall Medicare and in particular about HRA. It's a really HRA focused presentation for those participants who are already enrolled through us who are looking to get more information. We do make recordings of those trainings and the webinars, and we post them out to our website. That's specific to Nevada PEB, so participants can view those presentations. So we work really well with PEB to host those meetings and answer questions during those webinars for participants. We have a Q&A session at the end for people to chat in and online and ask questions that we respond to. So I think overall those presentations go really well. So those are the 2 additional slides that I wanted to mention in this report. And I'll go ahead and pause and see if there's any questions.
Yeah, Chris, I have a question. I'm just kind of curious. What are some of the reasons that participants are not utilizing their HRA accounts?
So thank you, Mr. Davis, for the question. Again, Chris Garcia with Willis Towers Watson. So what we found is one of the main things I think is education. We do send out, when somebody first qualifies for their HRA, we do send them out what's called a reimbursement guide, or basically it's an HRA guide, and it will advise them and give them information on how they can submit claims, how they can utilize their HRA. As I mentioned earlier, we do have a lot of automation built into claim submission. Even if somebody sends in a premium claim manually, we set that up as a recurring claim for the rest of the calendar year. So that that person only has to submit 1 claim for that calendar year. So we really try to make it useful. So what we've seen is a lot of people that aren't submitting claims right now. They're not familiar with how to submit claims or use the HRA. So education is a key thing. Another factor that we've seen is for participants that are enrolled in a Medicare Advantage plan. Many Medicare Advantage plans are very low cost premiums. So many of them are 0 cost premiums, in fact. So a participant who enrolls in a Medicare Advantage plan, that includes a prescription drug plan generally. And so if they're generally healthy, they don't have a lot of out-of-pocket expenses that they would need to submit for reimbursement. So maybe you have a retiree who they don't need glasses or they don't do a lot of dental work. So a lot of their expenses are already covered through their Medicare Advantage plan, and they're not really paying a large premium for that. So as they get their monthly allocation that PEB provides, if they're not submitting claims, then that balance continues to grow. And that's where we ended up, I want to say it was in 2020, the board decided to do the $8,000 cap. So we had a lot of accounts at that time who had well more than $8,000, and we had to reduce their balances to that cap. What we've seen now is more people are utilizing their funding as education has been made more prevalent. As PEB sends out those letters about the HRA cap coming up at the end of May, we see a lot more activity and as far as people submitting claims that could potentially be impacted by the cap. But you're still going to have people who just don't have those out-of-pocket expenses. However, we do also get a file from PEB for the PEB dental premium. So there's the PEB dental plan, and we receive that file regarding the PEB dental plan, and we load that automatically. So if somebody is enrolled in a PEB dental plan, we get that, we load that automatically as a premium against their HRA, and we reimburse them as a claim for that premium. Earlier in the meeting, there was a question, I believe during public comment, about the Medicare Part B premiums. And that's right now, it's like $202.90 for 2026. PEB participants can get reimbursed for that Medicare Part B premium as well. And we can help automate that for them if they are enrolled in a Medicare medical plan through us. And so again, that's education. A lot of participants don't realize that we can automate that. So even if they don't have an expensive Medicare Advantage plan or a lot of out-of-pocket expenses, they can still get reimbursed for their Medicare Part B premiums. So long as they're enrolled in a Medicare medical plan through us, we can automate that. There are some participants that receive an exception from PEB. It's called a TRICARE exception for having TRICARE coverage for serving in the military. If they have that TRICARE exception, they don't have to enroll in a Medicare medical plan through us. So they can still get reimbursed for their Medicare Part B premiums, but they would have to submit a manual form for that we could then set up as a recurring claim for the rest of the calendar year. But again, it comes down to, I think a lot of cases, it's education. It's getting information in front of these retirees. And we try to do that, Mr. Davis, with these retiree meetings that we do twice a year. We do them in the spring, and we actually have them coming up again in the fall. We'll be doing them in October. And we also put those videos on our website. There's a lot of education material on our website. So I think, in a roundabout way to answer your question, a lot of it comes down to education, people leaving money on the table because they don't know how to utilize the HRA for their benefit.
Thank you.
You're welcome.
Any additional questions?
Laura Rich for the record. I don't have an additional question, but I just wanted to bring up, especially given some of the public comment that we got. I would like to know if the board has any appetite to revisit our policy around requiring that retirees utilize the exchange in order to receive their HRA. I feel like it's my opinion that, we offer an HRA to retirees, they should be able to go use that wherever they want. And it also administratively, I know that it's a lot of work for PEB staff, and additionally, it's very cumbersome for our retirees who, they may be approached, come open enrollment season, they're approached by every plan, on the planet, and they are lured into other, other plans that are, potentially off the exchange. And then it becomes the whole effort of, oh no, now I'm not getting my HRA. And now you have to educate them, and you have to say, hey, you've got your one-time chance to come back. And by the way, you lost your life insurance. That's on NRS. We can't do anything about that. And now we have to administer it in-house and track all this. And so to me, I just feel like it's obviously Willis Towers Watson offers a benefit. It's good for retirees to use Willis Towers Watson, but I don't think that the board or that PEB should make it a requirement to utilize Willis Towers Watson. It's a retiree's HRA. They should be able to take it wherever they want. So that's my opinion. And I would just like to know, if there's any appetite to, look at that policy and revisit that policy, and maybe hear from PEB staff on, what that would look like. And also from retirees, in public option, I would love to hear that as well. I know that this has been hard on retirees, and PEB does everything they can to remind retirees before every open enrollment, hey, don't sign up for a Medicare plan off the exchange because you're going to lose your HRA and you're going to lose your life insurance. And so we do that. But of course, it's really difficult when, these are retirees. A lot of these are probably elderly retirees they have their family taking care of all of their issues, right? And so it's just something that I think that we should revisit.
Are there benefits with this plan that they don't get otherwise? Or what's the trade-off that would be?
So there are definitely perks to using Willis Towers Watson, right? They've got the customer service, they have, there's an automatic, they can automatically get reimbursements through their HRA. So that's all set up automatically. So there's definitely some benefits, but there's also plans that Willis Towers Watson doesn't have. And so, some people may feel that, going a different route is better for them as well.
And you're not suggesting we think about eliminating it, but just opening it up?
Yes.
Interesting.
Additional comments? That's not an action item, so. Additional comment. So I have a couple questions, Mr. Garcia. So there was a public comment earlier, and we've actually seen several public comment regarding the hometown health plans, basically network contraction. What is the availability of a special open enrollment for people who are having their primary care physicians or their regular providers eliminated as, in the middle of a
Right.
contract period?
Yeah, and that's a great question. Again, Chris Garcia with Willis Towers Watson. That's part of a challenge that I think is those retirees are in particular, I think, a Senior Care Plus retirees in Northern Nevada that are facing right now. CMS is very regulatory on when changes can be made to plans, in particular for Medicare Advantage plans. Medigap plans or Medicare supplement plans have more flexibility. They're not tied to what we would consider the Medicare open enrollment period. Medicare open enrollment period is right around the corner. It starts October 15th and goes through to December 7th. Changes made during that time are made for 1/1, the new year. So it would be 1/1/2027. And Medicare Advantage plans and prescription drug plans are tied to that Medicare open enrollment period. If a person who is in a Medicare Advantage plan is looking to change plans mid-year, they need what's called a special enrollment period. And loss of a provider does not allow them to make that change. So from my understanding and the research that I've done is that with the Senior Care Plus announcing that providers are going to be eliminated, and I believe it's effective at the end of this month for September 1, the participants that are in that plan or those impacted plans would have to wait until the Medicare open enrollment period to make changes for the 1/1 plan year. So that is unfortunately is what would occur. And so there sounds like for many of those participants who have a provider that is no longer going to be available to them through Senior Care Plus, they would have to wait until that open enrollment period to make changes for next year. So that's my understanding. I know that PEB has worked on some communications related to this, and I believe there's a memo on the PEB website. We are working with PEB to potentially send out a communication to potential impacted participants. That's something that we are currently discussing. But other than that, it sounds like the only change that they would make, unless they have some sort of other qualifying events, maybe if they move within the next month or two, then they can change, right? If you change zip codes, that would be considered a qualifying event, and you could potentially look at another plan in your new zip code that you would want to change to. If you have some other type of life event, there could be potential changes. The participant would want to speak to a benefit advisor by calling our service center to get that additional information to see what types of changes they can make based off of the life event that they're experiencing.
Disappointing in the
Yeah.
hometown
It-
health scandal,
it's
frankly.
it's pretty, to be honest, sir, it's unusual for me to see a carrier make a provider change mid-year like that for such a large group. Usually you'll definitely see provider changes happen during open enrollment. We get information about the new plan year in early October, in preparation for open enrollment starting October 15th. So we get that new provider information at that time as well. And that's when you'll see provider changes for the new year. It's very rare, in my opinion, to see those changes, those types of changes mid-year, is what we're seeing right now.
So these are Medicare Advantage plans, and so if they want to change to, and I don't know what, if their providers are on another Medicare Advantage plan in the north, but if they're not, then they need to be able to transition to a Medicare supplement plan. How difficult is that?
They can enroll in a Medicare supplement plan. Depending on their specific situation, there could be underwriting involved. Nevada PEB, or not Nevada PEB, excuse me, the state of Nevada has a birthday rule that does allow people to change Medigap plans if they're already enrolled in one. So the people that are enrolled in a Medicare Advantage plan, they may have to go through underwriting if they are now first choosing to elect a Medicare supplement plan, a Medigap plan. Not everybody will pass underwriting, or they could face larger premiums because of certain medical conditions. So unfortunately, that is an aspect of changing from a Medicare Advantage plan to a Medigap plan, to a Medicare supplement plan.
So what's the average number of people who are pass versus don't the underwriting process?
I don't have specific information on that. That's something I can reach out to our carrier team on and follow up accordingly.
I think we need to make sure that these individuals that are affected by this change have as many options as they can come open enrollment, and that they know what the process is going to have to be for the, to deal with the next, not just 3 months, but January going forward.
Absolutely.
All right. So yes, I'd appreciate a follow-up on that. Any other questions? Hearing none, also an information item. We'll close agenda item number 13, move to agenda item number 14. These are the information reports, the quarterly vendor reports for the period ending March 31st, 2026. Any questions on any of the individual reports? Seeing none, also an information item. We'll close agenda item number 14, move to agenda item number 15. Second public comment period. Again, public comment will be taken during this item, but no action will be taken on any matter raised under this item unless the matters are included on the future agenda as an item on which action may be taken. Public comments to the board will be taken under advisement, but will not be answered at the meeting. Again, I don't think we need to have any limitations on time. So please state and spell your name for the record. I'll start with you, Dr.
Thank you, Kent Irvin, Kentervin. I do appreciate the discussions today and especially the effort to put practice into written policy, which makes things more transparent and preserves institutional memory. Regarding Senior Care Plus, according to the Medicare website, a special enrollment period to change into a 5-star rated Advantage plan is allowed outside of open enrollment. And there is at least one of those available in Washoe that covers some of the providers, according to one of my retiree contacts. So could PEB and VIA Benefits verify that and include it in communications if that is really an option? On the UMR audit, extrapolating the net overpayments from the 200 random samples for each of the first 3 quarterly audits to all claims gives $25 million per year in potential overpayments. 25 million. 200 samples out of 250 claims seems insufficient, and it's clear that UMR is not fixing the problem on its own, and CTI is catching a minuscule fraction of the errors. So what savings are possible if PEB retained an independent payment integrity vendor to review every claim? My understanding, that's the way the industry is going. On the budget, My understanding was that the $30 million cost of the premium phase-in is relative to covering costs and completely replenishing reserves in 1 year. Also, the total actuarial reserves for FY 2027 went down by $5 million, mainly because of the $20 million low value for HRA reserves. So if the actuarial projections are correct, the reserves will rise and be just 25 million short by the end of fiscal year 2027 versus 74 million at the end of June. That's a big if, projections being accurate. Or maybe if UMR stopped overpaying claims, it would go down to, we would completely replenish reserves this year. Short-term cash flow issues could be a separate problem, but that's not the overall budget. On the discussion for setting dependent tier rates, those formulas from 2012 fixed a problem when they were separately related with the nonsensical outcome of a negative premium to add a child. The value for children of 37.5% of the adult rate may be different than actual costs. So that means children may already be effectively subsidized differently than spouses. So that's something to look at. There is value in keeping this formula simple and as uniform across plans as possible. Then regarding the rate settings for the 3 plan options, I learned today that the FY 2027 rates for each plan, that each plan was rated independently based on actual experience and participation. That's compared with past board policy, pooling experience across all 3 plans, and then presumably adjusting rates by the actuarial values, although that policy is not actually followed, resulting in severe cross-subsidization. I think it would be useful to see modeling of these 2 alternatives, separate rating versus pooling with adjustments for actuarial rates. It's a policy decision. I don't know how it works out, what's fair for participants. But the question is, and something that actuarial should be able to model, is how do those alternatives affect expected migration by different risk groups and future trends for the plan options. And then regarding Siegel's study on Medicare retiree costs, I didn't have time to review that report that was posted yesterday. But I suggest a deeper dive for the board to understand pre-Medicare retirees, Medicare exchange retirees, and those elderly retirees who will never be eligible for Medicare in the program. I don't know how many are left. What I do know is that the HRA subsidy for Medicare retirees has not been increased since 2019, and it has not kept pace with increases in Medicare B premiums and Medigap plan premiums. So thank you for your work and your consideration.
Thank you, Dr. Anyone else here at Carson City? Anybody online?
I have one, Chair Wells. I'll get the slide up in a moment. Caller with the last 4 digits, 8853. You have permission to speak. Please slowly state and spell your name for the record.
Doug Unger, D-O-U-G-U-N-G-E-R, immediate past president of the UNLV chapter of the Nevada Faculty Alliance and member of the UNLV Employee Benefits Advisory Committee. I'd also like to thank the board for the in-depth discussion today on almost all points. And I would like to also support my colleague Kent Irvin's suggestions for several different modelings of what might be possible to do with rates also based on past PEB practice. I would like to speak directly to agenda item number 8, which I did have a chance to review. And looking over the figures, I understood that these are perhaps Silver Age figures, given that they do not reflect the recent Plan D cuts by presidential executive order for the stabilization subsidies for Plan D, which are going to increase premiums in a range of $10 to $30. The best figure I've found is an average of $16 a month. Nor are they taking into account the $536 billion over 10 years that will be cut by the so-called Big Beautiful Bill that was passed
45 billion of which are going to hit this year. And looking over the possibilities for what this is going to do to the payments, I would guess that this is going to lower the actuarial values of all the Medicare plans under consideration there. But it brings up a larger issue, which is how stable really is Medicare and putting all our state employees unsubsidized onto Medicare. I have faculty colleagues who are looking at the California system, New Mexico, New Hampshire, Massachusetts, and wondering if they should actually move. Or international professors who are wondering if they should return to their home countries because Medicare is not a stable system and is clearly under siege. The HRA subsidy for retirees is a huge help and a huge compensation for the instability of the future of Medicare. And I do think it should be increased at least $1 a month for existing retirees hired before 2011. And please know that we are going to work very hard to try to restore the Medicare HRA subsidy for retirees for post-2011 hires. Thank you very much for all your service to the board, and thank you.
Thank you, Dr. Unger. Chair Wells, that concludes public comment. It concludes public comment. We'll close agenda item number 15, move to agenda item number 16, adjournment. Motion for adjournment.
Move to adjourn.
Member Reg, second. And all those in favor say aye.
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 Thank you all very much. See you.